Hello everybody, once again to another USMLE Step 2 CK review. This time we're going to be going over pulmonology for internal medicine. This is a audio review of my USMLE World notes. It's good to just listen periodically, maybe when you're in the car or in the gym or somewhere where you can't access books or whatnot, and it's just easier and is a good form of passive studying to just go over some of these notes. This is pretty complete from what I have done through UWORLD, so all of my notes are everything from what I've gathered from UWORLD. So let's start off with pulmonology in internal medicine. First topic is sarcoidosis. So the most common features of sarcoidosis epidemiology is that it affects young adults and African Americans. Clinically, they'll have constitutional symptoms, they'll have cough, dyspnea and chest pain, extrapulmonary findings like skin lesions, and anterior-posterior uveitis, as well as Lofgren syndrome. On imaging, there'll be bilateral hilar adenopathy and pulmonary reticular infiltrates, and on labs they show hypercalcemia and hypercalciuria. And the hypercalciuria occurs more frequently than the hypercalcemia, and that can then lead to a nephrolithiasis. Also in sarcoidosis, you'll have an elevated serum ACE level, and on pathology, you'll see biopsies showing non-caseating granulomas that stain negative for fungi and acid-fast bacilli. Some manifestations of sarcoidosis will be pulmonary manifestations, ophthalmological manifestations, reticuloendothelial, musculoskeletal, CNS, or endocrine manifestations, as well as Lofgren syndrome. So pulmonary manifestations would be your bilateral hilar adenopathies and your interstitial infiltrates. On ophthalmological manifestations of sarcoid would be peripheral lymphadenopathy as well as hepatosplenomegaly. And on musculoskeletal manifestations would be acute polyarthritis, especially around the ankles, and in chronic arthritis with periosteal bone resorption. The CNS system and the endocrine system will have central diabetes insipidus as well as hypercalcemia. And in Lofgren syndrome, this will show up as erythema nodosum, hilar adenopathy, migratory polyarthritis, and fever. Frequently, you have incidental findings on chest x-ray, and those can present with fever, cough, weight loss, dyspnea, and fatigue. And that may involve the kidneys, causing an interstitial nephritis or nephrolithiasis rather than a glomerulonephritis. Cardiac sarcoidosis is a myocardial infiltration and inflammation, and that's going to lead to conduction defects. So AV blocks are going to be the ones that are most common with cardiac sarcoidosis. Dilated cardiomyopathy as well. You also have valvular dysfunctions of heart failure that can cause sudden cardiac death. Definitive diagnosis is consistent with radiographic and clinical findings, as well as biopsy is going to demonstrate non-caseating granulomas. Bronchoscopy with transbronchial biopsy is done to obtain tissues, and these can be obtained from other sites which are involved, like the skin and the peripheral lymph nodes. Patients with incidental bilateral hilar lymphadenopathy without symptoms are going to be monitored without biopsy. Unless they start developing symptoms, then you'll biopsy them. Treatment for asymptomatic patients is to just monitor them without any type of medication, and that would be consisting of a high rate of remission. So for symptomatic patients, however, these patients are treated with systemic steroids, and you want to rule out infectious causes of the granulomatous disease. Because remember, other than sarcoid, they can have TB and histoplasmosis infections, and you want to check that out before starting steroids. For granulomatosis with polyangiitis, clinical manifestations here would be upper respiratory signs like sinusitis, otitis, saddle nose deformities. Lower respiratory involvement would have lung nodules and cavitations, and these can be accompanied by alveolar opacities. On renal, they can have rapidly progressive glomerulonephritis, and on the skin, they can present with livedo reticularis and non-healing ulcers. The diagnosis here is for granulomatosis with polyangiitis is that they have an ANCA, and on biopsy, on the skin, you'll see a leukocytoclastic vasculitis. On the kidney, you'll have that posse-immune glomerulonephritis, and on the lungs, you'll have granulomatosis with vasculitis. The management for granulomatosis with polyangiitis is steroids and immunomodulators like methotrexate and cyclophosphamide, or they can have rituximide can also be used. A vasculitis of the small and the medium-sized vessels most commonly affects white men and women ages between 30 and 50 years of age. The upper respiratory tract is most commonly involved, and they'll have narrowing and ulceration of the trachea involved, as well as auditory canal ulcerations. And this can be accompanied by anemia of chronic disease, as well as a mild leukocytosis. In HIV, there's an increased chance of false positive results of the ANCA, and that should be ruled out. So HIV should be ruled out because it gives you false positive results. And patients with clinical symptoms and positive ANCAs, you want to start treatment before confirming the biopsy. Breath sounds on auscultation, you'll have normal breath sounds. Percussion is going to be resonant. Auscultation is vesicular breath sounds or quiet inspiratory phases and almost inaudible expiratory phases. So those are all normal. For bronchial breath sounds, these are louder and they have prominent expiratory phases that provides that the airway is patent. If the airway is blocked, the breath sounds over the consolidated area will then be decreased. In the case of interstitial lung disease, fine crackles are going to be heard at the end of inspiration. Egophony, that's when you ask the patient to say the letter E and you want to listen with a stethoscope, and that E is going to sound a lot like a letter A with that nasally sound or a bleeding quality. Egophony means you basically have consolidation. Egophony can also sometimes be present in pleural effusions at the area of fluid accumulation due to a transmission of air through a collapsed area of the lung. So some pulmonary auscultation exam findings. So in a consolidation like a lobular pneumonia, you'll hear crackles, bronchial breath sounds, bronchophony, egophony, or pectoriloquy. That's musical breath sounds. Tactile phrenitis would be increased at consolidation sites, and percussion will be dull. So they'll have dullness on percussion, and that means that there's a large consolidation. But there's no mediastinal shift when it comes to consolidation. For pleural effusions, auscultation will hear decreased breath sounds. Tactile phrenitis, again, will also be decreased. Percussion will be dull. And here, with pleural effusion, the mediastinal shift would be away from the effusion, especially if there's a large effusion. For COPD, the auscultation is going to reveal that their breath sounds are decreased, and they'll maybe have a vesicular breath sound. Tactile phrenitis is also decreased. And percussion with chronic obstructive pulmonary disease is actually hyperresonant, especially if they have large bullae, but they do not have a mediastinal shift. Pneumothorax will have a decreased breath sound on auscultation. Their tactile phrenitis will be decreased, and on percussion it would be hyperresonant because of the pneumothorax. It's kind of like pounding on a drum. So mediastinal shift will be, if it's a small shift, there won't be that much of a shift, of a mediastinal shift. If there's a tension pneumothorax, it'll be away from the pneumothorax. Whereas if it's a spontaneous, it will be towards. So sound travels faster in solids than in air, and hence phrenitis, which is palpable vibration, is going to be increased in consolidation. Consolidation is also going to lead to bronchial breath sounds due to over-transmission of sounds over the chest wall. So in acute bronchitis, this is our next topic. Acute bronchitis is usually a viral infection. Patients are afebrile. Cough is going to be productive of purulent sputum, especially after a recent upper respiratory tract infection. Epithelial sloughing can make the sputum yellow and purulent, and it's not really a sign of a bacterial infection. It could be blood tinged due to the erosion of the small blood vessels from inflammation and epithelial damage, but that's not alarming. So if you see blood tinged sputum, that really doesn't tell you much, because it could be just irritation. Mild wheezing is going to reflect airway involvement, and rhonchi that improves with the cough suggests that the airway secretions can easily be mobilized, so that's a good sign. Clear lungs are going to be seen on chest x-ray, and treatment is basically supportive. No further evaluation is needed for small volume bronchitis, new onset blood, and no risk factors for malignancy or bronchiectasis. If they have recurrent bleeding, or a high risk of malignancy or an abnormal chest x-ray, or if they're stable but active bleeding, estimated to be more than 30 milliliters, then you're going to require a high resolution CT. Next up is cough, and the evaluation of cough could be subacute or chronic. So subacute is within 3 to 8 weeks. Chronic is more than 8 weeks of cough. So if you have suspected etiology on history and physical of a cough, you either have parenchymal disease or purulent sputum, or immunocompromised patient, or no specific etiology, just a suspected etiology on history and physical, you're just going to go right ahead and do a chest x-ray. Now, you also want to evaluate and treat as indicated with the suspicion of an etiology of whatever incidence on history and physical. If they're on ACE inhibitors, you want to stop the ACE inhibitor. If they have asthma, you want to check their PFTs. If they have GERD, you want to give them empiric PPIs. And if they have upper airway cough syndrome, then first generation H1 blocker is indicated. And if there's no improvement after any of these interventions, even after 2 to 3 weeks of therapy, go ahead and do a chest x-ray. Now, some of the common etiologies of chronic cough would be an upper airway cough syndrome. That's also known as a postnasal drip. There can be asthma and a cough variant asthma, also gastroesophageal or laryngopharyngeal reflux, post-respiratory tract infection, the use of ACE inhibitors, chronic bronchitis, chronic sinusitis, bronchiectasis, lung cancer, or a non-asthmatic eosinophilic bronchitis are all common etiologies of a chronic cough. So what is the definition of a chronic cough? Is the 3 most common causes of chronic cough is more than 8 weeks of cough. As an upper airway cough syndrome, that's a postnasal drip. There's GERD and asthma associated with it. Upper airway cough syndrome, like we said, is that postnasal drip. It can occur after a recent infection. The cough occurs at night, and it's caused by chronic rhinosinusitis. And those conditions are going to include allergic and perineal, non-allergic and vasomotor rhinitis. There could be acute nasopharyngitis and sinusitis. And the diagnosis, confirmation, and treatment is improvement of a nasal discharge and cough, and so improvement of the cough as well with first-generation antihistamines, like if you give them chlorpheniramine or a combination of antihistamine with a decongestion, like brompheniramine and pseudoephedrine. So next up is non-allergic and allergic rhinitis. So clinical features of non-allergic rhinitis would be nasal congestion, rhinorrhea, sneezing, postnasal drips. There's a late onset, and that's common, so this usually occurs when they're older than 20 years of age. Also, no obvious allergic triggers with non-allergic rhinitis. There's perineal symptoms that can worsen by season, and there's an erythematous nasal mucosa. Now, the treatment for non-allergic rhinitis, if it's mild, would be intranasal antihistamines or steroids. And if it's moderate to severe, then you want to give a combination therapy. So that's non-allergic rhinitis. For allergic rhinitis, here you have your watery rhinorrhea. You have sneezing, it's allergic. Eye symptoms, so runny eyes, red eyes. It's earlier age of onset. There's going to be an identifiable allergen, or there's some kind of seasonal pattern that it happens in the fall or in the spring. They can have pale bluish nasal mucosas, and these are associated with other allergic disorders like eczema and asthma, and as well as eustachian dysfunction. Treatment for allergic rhinitis would be intranasal steroids and antihistamines. So non-allergic rhinitis is also known as vasomotor rhinitis. The diagnosis is made mainly clinical. There's a routine allergy testing, which is not necessary before you give them empiric therapy, but there is allergy testing. Plain radiographs are performed, and if symptoms suggest chronic sinusitis, then you do the plain radiographs. Non-allergic rhinitis patients with prominent rhinorrhea and postnasal drip or a dry cough sometimes respond to first-generation antihistamines, but they rarely respond to antihistamines without anticholinergic properties like loratadine. So giving them that, loratadine is not going to help. It has to be antihistamine with anticholinergic. Topical intranasal antihistamines would be like olopatadine or azelastine. Now, next up is going to be ventilator. So all the things that we need to know on ventilator settings and definitions and whatnot. So the PaO2 in a ventilator is going to measure oxygenation. Mainly it's influenced by FiO2 and PEEP. The PaCO2 is a measure of ventilation, and that's affected by respiratory rate and tidal volume. So basically, if you want to adjust things that affect oxygen, you're going to adjust on the ventilator FiO2 and PEEP, peak expiratory end pressure, right? Versus if you want to adjust things that are PCO2, that's going to measure ventilation, then PCO2, you're going to want to dial in their respiratory rate and tidal volume. Okay, so normal FiO2 at sea level is 0.21 or 21%, and patients are often provided a high FiO2, any more than 80% initially in mechanical ventilation, pending the results of the first arterial blood gases. Ventilator settings can be changed based on the results. So the goal of oxygenation is going to be greater than 60. It's an important early goal in the initial ventilator management, and that should be used to decrease the FiO2 to non-toxic values. There's no strict cutoff for FiO2 values for oxygen toxicity, but the levels below 50 to 60% are going to be desirable. So a decrease in FiO2 when the PaO2 is increased, you want to add PEEP if adequate oxygenation isn't going to be achieved just on the high FiO2. So if you basically have your FiO2 settings high and the patient's not ventilating or it's not oxygenating, then you want to add PEEP. You want to add that pressure to keep those alveolus open and have more time with the oxygen diffusion. Now, assist control mode of mechanical ventilation, that's going to deliver a predetermined tidal volume with every breath. That's what assist control does. It just gives you enough tidal volume every time you breathe in. Inspiratory cycles can be initiated by the patient, but if the patient fails to breathe at a set minimum rate, then that ventilator will deliver the tidal volume on its own. So it's an assist. So if the patient can't breathe on its own, that's when the ventilator will kick in. Assist control mode. Now, normal tidal volume is delivered at 6 milliliters per kilogram of the ideal body weight. In patients with ARDS, mechanical ventilation is going to improve oxygenation by providing an increased fraction of inspired oxygen, and it's also going to provide PEEP to prevent alveolar collapse. When the FiO2 is going to be decreased below 60%, PEEP is going to then can be increased to maintain that adequate oxygenation. If respiratory alkalosis is present, so if they give you a high pH with a low PCO2 and an increase in PO2, if that develops at appropriate tidal volumes being delivered, then the respiratory rate should be lowered. and reductions in tidal volume can trigger an increase in ventilatory rate, and that causes an exacerbation of the situation. All right, so next topic is ARDS, or acute respiratory distress syndrome. Risk factors here would be infections, trauma, a massive transfusion, or acute pancreatitis. Pathophysiology of ARDS would be lung injury, and that's due to fluid or cytokine leakage into the alveoli and impaired gas exchange, as well as decreased lung compliance and pulmonary hypertension. The diagnosis of ARDS is a new worsening respiratory distress within 1 week of an insult, with bilateral lung opacities showing pulmonary edema, and that's not due to CHF. That's very important. So if you see bilateral lung opacities, the first thing you want to do is kind of rule out CHF. If that's ruled out, then that's ARDS. CHF or fluid overload. Hypoxemia with a PaO2 FiO2 ratio of less than 300 millimeters of mercury, that would be a diagnosis of ARDS. So that PaO2 FiO2 ratio of less than 300 is important. So just remember that. Less than 300 is hypoxemia with ARDS. Management is mechanical ventilation with low tidal volume, a high PEEP, and permissive hypercapnia. A normal pulmonary capillary wedge pressure with ARDS. The leakage of bloody and proteinaceous material into the alveoli, alveolar collapse, is going to be due to a loss of surfactant, and diffuse alveolar damage is going to lead to a impaired gas exchange because of the VQ mismatch. Lung compliance is going to be decreased, so that ability to expand the lungs is decreased because they're stiff due to both loss of the surfactant and an increase in the elastic recoil of the edematous lungs. Pulmonary arterial pressure is increased, so they'll have pulmonary hypertension, and that's due to hypoxic vasoconstriction, a destruction of the lung parenchyma, and compression of the vascular structures from a positive airway pressure in mechanically ventilated patients. Next up, so what's the criteria for ARDS syndrome? So new or worsening respiratory symptoms during the past week or within a week of a known clinical insult is one of the criterias. Another one is a bilateral lung opacities on imaging consistent with pulmonary edema. So the way I like to see it is those fluffy white infiltrates on a chest x-ray. They look like a bunch of cotton balls inside the lung. No sign of cardiac failure or fluid overload, yet they have this worsening respiratory symptom acutely. That's another criteria. Objective assessment, so on echocardiograph, to definitively exclude hydrostatic pulmonary edema in patients without ARDS risk factors. That would be another criteria. So basically ruling out pulmonary congestion and edema due to, let's say, CHF. And then severity of hypoxemia is defined by a pulmonary arterial oxygen FiO2 ratio of less than 300 with a PEEP more than 5. So mild ARDS would be a PaO2 FiO2 ratio between 200 to 300. Moderate would be between 100 to 200, and severe would be less than 100. So they can ask you the severities of ARDS. So just knowing less than 300, it may not be good enough. So less than 300 is your cutoff. 2 to 300 is mild. Less than 200 is moderate. And less than 100 is severe. So in cases of pancreatitis, you have increased circulating pancreatic enzymes, and that's due to a breakdown of the endothelial membrane. There's an increase in circulating inflammatory cytokines, and that causes diffuse alveolar damage. Those inflammatory cytokines are going to cause damage to the alveolus, causing there to be an impairment of gas exchange. Because there's an impaired gas exchange, there's also a decrease in lung compliance with the alveolar damage of this inflammatory cytokines. There's also pulmonary hypertension, which is going to require invasive mechanical ventilation. Also, diffuse crackles can be heard on lung examination, and basically ARDS is a diagnosis of exclusion, right? You want to exclude any kind of cardiac cause of the pulmonary edema, and once you achieve that, check out the PaO2 FiO2 ratio. If it's less than 300, you got yourself your ARDS. Next up is hypoxemia. So what are the causes of hypoxemia? Would be a decrease in inspired oxygen tension because there's low levels of oxygen in the blood. Hypoventilation, it's a diffusion limitation. There can be a shunt involved or a VQ mismatch. The AA gradient is going to help determine the specific cause of hypoxemia. It's a measure of oxygen transfer from the alveoli to the blood. So a normal value of an AA gradient is less than 15. So values are going to increase. They're going to increase normally with age, but any value more than 30 at any age is going to be considered abnormal. So there is a calculation for alveolar oxygen tension, but I really don't think it's worth your time memorizing it. So let's move on. So we have hypoventilation. This is a high PaCO2 of between 50 to 80 and a low PaO2. So because you're hypoventilating, you're retaining carbon dioxide. You're not breathing out. So this is going to cause alveolar hypoventilation plus a respiratory acidosis. So what are the causes of this hypoventilation? It could be a pulmonary and thoracic disease like COPD. It could be obesity, hypoventilation, or scoliosis. It could be due to neuromuscular diseases like myasthenia gravis, Lambert-Eaton syndrome, and Guillain-Barré syndrome. Drug-induced hypoventilation would be like anesthetics, narcotics, sedatives. Primary CNS dysfunction is also going to cause hypoventilation if there's a brainstem lesion or if there's an infection or a stroke. And here in hypoventilation, the AA gradient is normal in hypoventilation and reduced inspired oxygen tension. So remember, AA gradient is basically, the way I like to remember it is that it's the difference in percentages of oxygen in the blood and in the alveolus. So that in between the blood and the alveolus, that's where you want to do your oxygen exchange. So if there is any kind of wall there, anything that's preventing that oxygen exchange, anything, sarcoidosis, wiping out surfactant, pulmonary embolism, tension pneumothorax, spontaneous pneumothorax, something that'll just block any kind of oxygenation between the alveolus and the blood supply is going to increase your AA gradient because it's going to build up either behind the big A or it's going to build up behind the little a. So that AA gradient is then going to be abnormal. So that's the way I like to remember it. Okay, so what are the effects of arterial oxygenation and ventilation in various environments? So, for example, you have in high altitudes, right? There is a reduced inspired oxygen tension. So the AA gradient when you're in high altitude is normal because there's no physical barrier between the diffusion of oxygen there. It's just that there's a reduced amount of oxygen tension in the atmosphere. So the AA gradient is normal, the PaCO2 is normal, and will it correct by giving them oxygen? Yes, it will, because here the problem is that there's not enough oxygen tension. So what would be another example would be CNS depression. So CNS depression basically is causes hypoventilation. Here again, the AA gradient is normal because there's no physical barrier that's preventing that diffusion. So the AA gradient is normal when you're hypoventilating. But you're hypoventilating, so you have an increase in CO2. And will this correct with supplemental oxygen? Yes, it will, because this has to do with CNS depression. Another example would be interstitial lung disease. So interstitial lung disease, here you have a diffusion limitation. So guess what? The AA gradient here is going to increase. The CO2 is normal. It does correct with supplemental oxygen, but since you have interstitial lung disease that's preventing a facilitated diffusion between the alveolus and the blood supply, then your AA gradient will be increased. If you have a shunt, like an intracardiac shunt or extensive ARDS, this is also going to cause the AA gradient to increase. But here your CO2 is normal, but since it's a shunt, will it correct with supplemental oxygen? No, it won't, because here the problem is that you're shunting the blood supply somewhere else. So no matter how much oxygenation you give it, if it's not going to the correct area because of a shunt, then it will not correct with supplemental oxygen. And finally, in obstructive lung diseases, in atelectasis, and pulmonary edema, and pneumonia, like I said earlier, this is all causing a physical barrier, and here you're causing that AA gradient to increase. And also you're causing a VQ mismatch as well with obstructive lung diseases, atelectasis, pulmonary edema, and pneumonia. The CO2 is going to be increased, or it's going to be normal, but it does correct with supplemental oxygenation, because here there is a limitation of oxygen being delivered because of these diseases. So in other words, everything is basically going to correct with oxygen. Not at the best corrections possible, but it will correct at some point. The only one that won't is a shunt, because it makes sense. Your body's shunting it to a different location. Why would it correct itself if it's not going to the proper area because of a shunt? All right, next one would be an obstructive sleep apnea. So the pathophysiology of obstructive sleep apnea is relaxation of the pharyngeal muscles that leads to a closure of the airway. So they present with loud snoring, with periods of apnea. So how do they present? What are the symptoms? They'll present to you a patient that falls asleep during the day or has daytime somnolence. They have non-restorative sleep with frequent awakenings and morning headaches, affective and cognitive symptoms. Just be careful with the morning headaches, because also tumors and malignancy are also associated with morning headaches. But here, if they have morning headaches with daytime somnolence, and if they're obese and they have snoring, think of obstructive sleep apnea first. It also affects their cognitive symptoms and functions. And the sequelae of obstructive sleep apnea would be a systemic hypertension, pulmonary hypertension, and right heart failure. So obstructive sleep apnea occurs either alone or with obstructive hypoventilation syndrome. In obstructive sleep apnea, the hypoventilation only at night, and that it's a hypoventilation that's only at night with transient hypoxia and hypercapnia that resolves while they're awake. It happens more often in men than in women, and the incidence increases with age until they're about 65 years old. Also, obesity and a small mandible can also cause obstructive sleep apnea. An increase in soft tissue, because that increase in soft tissue can prevent that airway to maintain patency. A tonsillar hypertrophy are also all risk factors. They're preventing that airway to let in a nice flow of oxygen. So complications here would be depression, accidents due to daytime somnolence, impotence as well. And the diagnosis is through a nocturnal polysomnography. That's the gold standard, nocturnal polysomnography. There's two types of abnormal ventilation during sleep. So you have apnea, which is a cessation of breathing for more than 10 seconds, and you have hypopnea, which is a decrease in airflow causing an SaO2, or the saturation of oxygen, to decrease more than 4%. That's hypopnea. Hypopnea. All right. And the diagnostic criteria for obstructive sleep apnea would be if they're experiencing more than 15 obstructive respiratory events per hour. That's diagnostic. Apnea or hypopnea. And obstructive sleep apnea, as well as obesity hypoventilation syndrome, these are morbid obesity. These are associated with morbid obesity, with neck fat It's going to cause that airway to collapse. Fatigue, sleep disturbances, and progressive dyspnea on exertion. In obesity hypoventilation syndrome, there's a physical restriction of the thoracic cavity that's going to cause an excess in thoracic tissue that's going to continue throughout the day. Chronic hypoxia and hypercapnia. It's gonna cause the kidneys to increase bicarbonate. That way they can maintain pH, and that is also going to decrease chloride reabsorption, causing a compensatory metabolic alkalosis. Because of that, you'll have a decrease in ventilatory response with an increase in CO2, and that's because of a hypoventilation. Now, chronic hypoxia is due to pulmonary hypertension. That could be one of them, due to hypoxic vasoconstriction or cor pulmonale. An isolated obstructive sleep apnea and obstructive sleep apnea with obesity hypoventilation syndrome, that also causes hypoxia, and that's due to a sympathetic nervous system response that's going to cause increase in catecholamines and then systemic hypertension as well. So obesity hypoventilation syndrome, the diagnostic criteria is a BMI that's more than 30. They have awakened daytime hypercapnia, so CO2 more than 45 while they're awake. And there's no alternative causes of the hypoventilation. It's caused by the obesity. Now on workup, on ABG, on room air, there's hypercapnia and there's a normal AA gradient. There's no intrinsic pulmonary diseases on chest x-ray, and they have a restrictive pattern on pulmonary function tests. There's a normal TSH, and you'd also want to do a polysomnography. Okay, treatment of obstructive obesity hypoventilation syndrome is a nocturnal positive pressure ventilation that's used first-line therapy, so like a CPAP machine. Weight loss, like bariatric surgery in selected cases, so they're extremely morbidly super obese. Bariatric surgery is indicated. Besides that, then weight loss is a good treatment. Avoidance of any kind of sedative medications that can exacerbate the problem, and respiratory stimulants like acetazolamide are used as a last resort. Next up is pulmonary embolism. So pulmonary embolism can be either due to a DVT or fat embolism. So a DVT is a common source of a pulmonary embolism, and this is the deep veins of the lower extremities are going to be the most frequent source. There's lower extremity deep vein thrombosis. This is divided into two categories. So it's either going to happen at your proximal thigh or your distal calf. The proximal thigh, like your iliacs or the femoral or popliteal areas, these are the sources of more than 90% of acute pulmonary embolisms. It's probably due to the large caliber and the proximity to the lungs. So if you're ever asked the question, where's the most common this person had a pulmonary embolism, where did it most likely originate in? And you're going to say it's the proximal thigh, somewhere within the iliac, femoral, or popliteal region. Okay. Then your distal calf, these are less likely to embolize and more likely to spontaneously resolve. They're further away, and because of the caliber, they're going to be smaller. So that's why it's not as problematic. Now, fat embolism, this is common in patients with polytraumas, especially after multiple fractures of long bones. This can occur 12 to 72 hours after trauma. Signs and symptoms would be severe respiratory distress, petechial rashes, subconjunctival hemorrhages, tachypnea, tachycardia, and fever. They have CNS manifestations that initially starts off with confusion and agitation, but then can progress to stupor, seizures, or coma, and frequently they become unresponsive to correction of the hypoxia. The diagnosis is the presence of fat droplets in the urine or intra-arterial fat globules on fundoscopy. Thrombocytopenia, anemia, and hypofibrinogenemia are non-specific findings. And on serial x-rays, you'll show increasing of a diffuse bilateral pulmonary infiltrates within 24 to 48 hours after the onset of clinical findings. And the treatment of a fat embolism would be prompt respiratory support give them heparin, steroids, and low molecular weight dextrin is all controversial. So here you want to just give them prompt respiratory support. This is probably one of my favorite questions because it's so fast and easy to get right. You don't have to read too much on the vignette. They're going to come in car accident or something where they have a broken bones or something, and suddenly they present with a severe respiratory distress and a petechial rash and subconjunctival hemorrhages. Right there, click fat embolism and move on. Love that question. Amniotic fluid embolism occurs immediately after the rupture of membranes, and it's not during pregnancy generally. So the management and approaches to a pulmonary embolism would be first to stabilize the patient and give them oxygen and IV fluids. So that is always first line. Stabilize them, give them oxygen and IV fluids. Then you want to evaluate for absolute contraindications to anticoagulation, because the next thing on your mind is let's give them anticoagulation. So if they do not have any kind of contraindications, then you want to assess clinical suspicion of a pulmonary embolism with the modified Wells criteria. So basically you're going to ask yourself, does this person have a likely PE, or is it unlikely that they have a PE? If it's unlikely, then you want to obtain a diagnostic test to evaluate for a PE. Usually that diagnostic test is going to be like a D-dimer. If it's positive for a PE, you want to start or continue anticoagulation and consider surgery or thrombolytics if indicated. But if your gut instinct was that it wasn't and it's negative for a PE when you did that diagnostic test, then you want to just stop the anticoagulation. If you went back and you have the clinical suspicion of an embolism and you're thinking, yes, this person most likely does have an embolism, then you want to consider right off the bat anticoagulation. Even if the patient has no relative contraindications, moderate to severe distress, you want to consider anticoagulation. And then again, you want to obtain the diagnostic test to evaluate for a PE. If it's negative for a PE, you want to stop the anticoagulation. But if it's positive, your gut instinct was right. You want to continue them on that anticoagulation and consider surgery or thrombolytics if indicated. Now, what if we stabilize the patient, gave them oxygen and IV fluids, and after you evaluated them for absolute contraindications to have anticoagulation, they do have contraindications. You can't just go ahead and anticoagulate them. First, you want to obtain a diagnostic test to evaluate for the pulmonary embolism before you anticoagulate them. If they are negative for a pulmonary embolism, then you don't have to do anything else. But if they do have a pulmonary embolism and you cannot anticoagulate them, then you want to start considering the inferior vena cava filter. And we'll go into detail in a second. So signs and symptoms of acute dyspnea and pleuritic chest pain are the most common. There's also hemoptysis, a DVT, tachypnea, tachycardia, as well as low-grade fever. In an acute pulmonary embolism that can cause bilateral wheezing due to cytokine release in response to the hypoxia and the infarction. On EKG, this can show prominent S waves in leads 1 and a Q wave in lead 3 and an inverted T wave in lead 3. So this is where you have your famous S1, Q3, T3. An S in lead 1, a Q in, in lead 3, and a T in lead 3. So on chest x-ray, you're going to have something called a Hampton's hump or a Westermarck sign, which is less common. But anyway, on chest x-ray, those signs are basically the wedge shape infarct. It looks like a Dorito or a slice of pizza. Okay, and atrial fibrillation, this is due to atrial strains from an increase in right atrial pressure. Low oxygen saturation and atrial fibrillation are poor prognostic signs. So we said earlier, how would you suspect pulmonary embolism? And it's through a modified Wells criteria. That's how you would clinically assess for a pulmonary embolism. So you do the Wells criteria and you say, you know what, this patient probably does not have a pulmonary embolism, but we still got to try and test them out. What test would you do if it's unlikely? It's the D-dimer. So a D-dimer is, the magic number here is 500. So if it's less than 500 on D-dimer, then you're right, there is no PE, it's been excluded. But if the D-dimer is higher than 500, then a pulmonary embolism is not excluded. So you have to go to the next step, which is a CT pulmonary angio. If the pulmonary angio is positive, then you have confirmed the PE. But if the angio is negative, then you excluded the PE. But let's say you did think this person has a PE. What do? You don't do a D-dimer. You go straight into CT pulmonary angiograph. And in that CT pulmonary angiography, again, if it's positive, the PE is confirmed. If it's negative, it's excluded. So CT angio is the diagnostic test of choice. A VQ mismatch is checked in those with significant renal impairment, with morbid obesity and or contrast allergies. Echocardiograph can be done in patients that are highly unstable to tolerate a CT angio and look for changes in the left ventricle. A VQ mismatch is going to cause an increase in the AA gradient. Remember, that's the physical barrier. It's going to increase more than the expected AA. So the PaO2, we don't have to calculate it, but it's simplified for patients breathing at room air or sea level is going to be, a PaO2 is going to be 150. The expected AA gradient is another calculation that we don't need to go over. And a D-dimer assay is used to exclude PE in those who are unlikely to have a PE, but it's a negative test cannot be used to exclude a PE in those who are likely to have a PE. So basically, if you don't think they have a PE, do a D-dimer. If you think they have a PE, go straight into CT angio. But if you don't think they have a PE, you do the D-dimer. It's more than 500, then they might have a PE. Then you do the CT angio, and then that will either confirm or deny the presence of a PE. So finally, all this talk on the Wells criteria. What is the Wells criteria? A modified Wells criteria for pre-test probability of a PE is scored on points. So you have 1 point, 1.5 points, and 3 points. Less than 4 points is likely to be a PE. More than 4 points is likely. So let's start off with the 3 points. You get 3 points if you clinically have signs of a DVT. So long flight, obese, or with pain in the calves. There you go. That's 3 points right there. Alternative diagnosis is less likely than a PE. You still get 3 points. If you're able to come up with a diagnosis that's less likely than a PE, automatically get 3 points. So what gets 1.5 points? So if they've had a previous pulmonary embolism or DVT, you automatically get 1.5 points. If the heart rate is tachycardic at more than 100, you get 1.5 points. And if you've recently had a surgery or you have been immobilized for a long period of time, you get 1.5 points. And 1 point if you have either hemoptysis or cancer. And again, less than 4 points, you're unlikely to have a PE. More than 4, it's very likely. So what do we say if it's very likely? CT angio. Unlikely, D-dimer. Okay, treatment. Immediate anticoagulation is done unless contraindicated. Many options are available, like low molecular weight heparin, which is like enoxaparin. There's oral factor 10A inhibitors like rivaroxaban. And remember, the XA in rivaroxaban is 10A. That helps. And injection factor 10A inhibitors like fanduparinox. These three can't be used in severe renal insufficiency with a GFR that's less than 30 milliliters per minute, as reduced renal clearance is going to lead to an increase in anti-10A activity, and it's also going to cause an increase in bleeding risk. So what do you do if somebody needs this? They need to be anticoagulated, but they can't use heparin because they have renal failure or problems with creatinine. Then you give unfractionated heparin. Unfractionated heparin is used in these patients as its therapeutic levels are easily monitored with a PTT. Once heparin produces the therapeutic anticoagulation, which is 1.5 times the normal PTT, then you can start warfarin. So you have that heparin-warfarin bridge, and that usually takes 5 to 7 days to reach therapeutic levels. Then after reaching a therapeutic INR, heparin can be stopped and warfarin is going to be continued long term. So that heparin-warfarin bridge at 5 to 7 days to reach an INR that's therapeutic, then you can stop heparin and continue them on warfarin. Next up is pulmonary embolism or massive pulmonary embolism, pathophysiology of a submassive or a massive pulmonary embolism. So a massive pulmonary embolism causes a right ventricular outflow obstruction. Oh crap. So that's huge. Right ventricular outflow obstruction, and that's going to cause an increase in right ventricular pressure. Because of this, your wall tension in the right ventricle is, guess what, going to be increased. And that right ventricular myocardium is also going to have an increase in oxygen demand. This is going to unfortunately lead to right ventricular ischemia or infarction, which is going to cause a right ventricular hypokinesis and dilation. But again, that obstruction and increase in right ventricular failure or right ventricular pressure is also going to cause right ventricular hypokinesis and dilation. So it does it 2 times. Then that increase in right ventricular wall tension and an increase in the myocardial oxygen demand is also going to cause a decrease in coronary perfusion, and it's also going to decrease the right ventricular myocardial supply, giving them ischemia or an infarction, hypokinesis, and dilation of the right ventricle. If you have hypokinesis and dilation of the right ventricle, then there's a decrease in right ventricular cardiac output, and there could be septal deviation towards the left ventricle. And if there's septal deviation towards the left ventricle, then the preload in the left ventricle is going to decrease and cardiac output's also going to decrease. And if you get a decrease in cardiac output and a decrease in left ventricular preload, again, you'll have a decrease in myocardial oxygen supply to the right ventricle, as well as a decrease in coronary artery perfusion, which is going to lead to a right ventricular ischemia and infarction, hypokinesis and dilation, and it's a endless cycle there. Okay, so significant dyspnea, hypoxia, tachycardia, which is a bradycardia and complete heart block. Also clear lungs, chest pain, syncope, hemodynamic collapse, and an elevated jugular venous pressure is seen with a massive pulmonary embolism. There can be septal deviation that occurs, consisting of right ventricular pressures increasing more than the left ventricular pressure, and a right ventricular dysfunction with an elevated BNP and troponin is going to increase mortality because of the ischemia infarction risk. Now let's talk about flow volume curves. So you have a fixed upper airway obstruction. That's just going to limit the airflow during inspiration and expiration. So what does that do to the volume loop? It's going to flatten the flow. It's going to flatten the flow on the volume loop. This can be caused by a laryngoedema, which can be secondary to a food allergy. And so here the treatment would be epinephrine or systemic steroids and antihistamines. I mean, you can have a test question that will say, what would be the next best treatment for this patient? But you don't need a flow volume loop or a curve to tell you this patient most likely had a food allergy. They're going to give you a scenario where they most definitely had a food allergy, and then the flow volume curve is just going to be there as an added bonus. But you don't need to spend time fixated on that curve. You can get all you need to know to answer that question correctly just on that. But if you do need to know what is causing the flattening of the flow volume loop, that is the fixed upper airway obstruction. So an obstructive pattern causes intrapulmonary airway obstruction due to a bronchoconstriction. So this is going to decrease the airflow during effort, independent phase of exhalation. And that's going to cause a scooped out pattern during exhalation on the flow volume loops. So in a normal patient, the flow volume loop is going to have that, I would say like a ramp or like a shark fin on the top. And then on the bottom on inspiration, it's just going to be a loop. So on inspiration and COPD or obstructive lung diseases, the inspiration isn't a problem. It's the expiration that's a problem. And it doesn't look like a shark fin anymore. It looks like somebody took a chomp off of that shark fin. So there's going to be a scooped out pattern. In a restrictive lung pattern, here you're just going to see a smaller version of the loop. So let's say in a pneumothorax, you have a decrease in lung ventilation by preventing complete expansion of that affected lung. That's a restrictive pattern of the flow volume loop. Pulmonary edema is going to decrease the lung compliance, and it's going to cause a decrease in lung ventilation, and that's your restrictive pattern. So here you have, again, that shark fin on the top on expiration and that U loop on inspiration. The restrictive pattern on the same flow volume loop is going to look identical. It's just going to be smaller. So expiration, instead of going all the way to, let's say 8, it goes only up to about 4. And inspiration, instead of going all the way down to, let's say 7 or 6, it goes only up to about 3. So that's how you see it. The scooped out is obstructive. The just the smaller loop is a restrictive. Spirometry is the next. So on spirometry, you're gonna see either you're gonna see a low FEV1 FVC or a normal to high FEV1 FVC. If you have a low FEV1 FVC on spirometry, this is an obstructive disease. Remember, FEV stands for forced expiratory volume or forced vital capacity. So if expiratory volume is low, you're not expelling anything on expiration, so you have an obstructive disease. So what do you do next to find out if you have, let's say, either COPD or asthma, is that you want to see if they will bronchodilate with a bronchodilator challenge. So you try to open up the airways pharmacologically. If after the bronchodilator challenge you have an increase in FEV1, then your problem here is asthma. But if it doesn't, if there's no change in FEV1, then your problem is COPD. If on spirometry your FEV1 FVC is normal or high, but your vital capacity is low, here you have a restrictive disease. So what do you do next? You check the DLCO. What is a DLCO? DLCO stands for diffusion limited carbon monoxide. It's a test where you get a little bit of carbon monoxide, which we all know diffuses faster than regular oxygen. So if your lungs are able to diffuse it, then you don't have an interstitial lung disease. You have a chest wall weakness. So if the DLCO is normal and you are able to diffuse oxygenation somehow, then this is just due to a chest wall weakness. You're just not inspiring enough. But if the DLCO is decreased, that means that there's a barrier. That means that you have interstitial lung disease. And again, the AA gradient is increased. I'm not going to stop with that analogy. All right, next is obstructive lung diseases. COPD is a combination of chronic bronchitis and emphysema. So chronic bronchitis is going to cause cough and sputum production for more than 3 months in 2 successive years and an abnormality of a bronchobrachial tree with prominent bronchial vascular markings with mildly flattened diaphragms and a normal DLCO. So again, because it's obstructive, your DLCO is going to be normal. Emphysema is going to have severe dyspnea, hyperinflated chest, with a decreased vascular markings. There's a decrease in DLCO, however, in emphysema. And that's due to alveolar damage and moderate oxygen desaturation, and that's usually centriacinar emphysema. But either one of those can be predominant. So these are two causes of an obstructive lung disease. It could be a combination of both. Therapies that prolong the survival in COPD would be to stop smoking if smoking is an issue. Supplemental oxygen and lung reduction surgery in certain patients. So by giving them oxygen will actually help. Long-term home oxygen therapy is actually a very, very widely used therapy that's very common. It decreases mortality. So progressive hypoxemia is common in patients with advanced chronic obstructive pulmonary disease, and studies have shown there is a survival benefit if you use long-term home oxygenation therapy. Those are the people that you see with a tank of oxygen and nasal cannulas on the streets and at home. This is a very effective way of increasing survival in those with significant chronic hypoxemia. And the criteria for initiating that home oxygen therapy in patients with COPD means that your resting arterial oxygen tension is less than 55, or if you have a pulse oxygen saturation that's less than 88% on room air. Pulmonary oxygen is going to be less than 59, or an oxygen saturation less than 89 in patients with cor pulmonale, or evidence of right heart failure, or a hematocrit that's greater than 55%. And the dose of supplemental oxygen should be titrated so that the oxygen saturation is going to be maintained at levels that are higher than 90% during their sleep or normal waking or at rest. And the survival benefits of home oxygenation therapy are very significant when it's used more than 15 hours a day. So the more you use it, the better it is. Then you have phosphodiesterase inhibitors with anti-inflammatory properties like roflumilast. These decrease mucillary clearance, decrease mucillary malfunction and pulmonary remodeling, and that's used in maintenance therapy for COPD, but it's not good for acute exacerbation. So that's another therapy that could be considered. But home oxygen therapy is going to be on the test. That is tested, and it does increase survival. And the remainder of the therapies would be given to decrease respiratory symptoms and improve quality of life, as well as decrease hospitalizations. And those are going to include inhaled bronchodilators, especially anticholinergics like ipratropium or tiotropium. Those are mainstays of treatments and they could be combined with either short-acting beta agonists like albuterol and inhaled steroids as well, with long-acting beta-2 agonists if there's more severe symptoms of COPD. Is acute exacerbation of COPD, and an acute exacerbation of COPD, your cardinal symptoms. So you have increase in dyspnea, increase in cough that's more frequent or severe. There's also sputum production and a change in color or volume. Diagnostic testing would be a chest x-ray, and that's going to show hyperinflation, and on ABG showing hypoxia, CO2 retention, chronic and or acute carbon dioxide retention. Management would be oxygen, and the target of the oxygen would be a specific oxygen of 88% to 92%. Also inhaled bronchodilators, systemic steroids, antibiotics as well, if more than two of the cardinal symptoms are there, like the dyspnea or the cough, the sputum production. Also tamivir if there's evidence of influenza, and non-invasive positive pressure ventilation if they have ventilatory failure, or tracheal intubation if the non-invasive positive pressure ventilation failed or it's contraindicated. So the acute exacerbation of COPD is often triggered by recent upper respiratory tract infections. JVD can be observed, especially during expiration, because there's going to be an increase in intrathoracic pressure. So systemic steroids, those are going to cause a decrease in inflammation, and that's associated with a COPD exacerbation. And it could also improve the lung function as well as the hypoxemia, and that leads to a decrease in risk of relapse. Also, it decreases the risk of helps with treatment failures and lengths of hospital stays. And that's going to be administered for 5 days as oral prednisone or IV methylprednisolone. IV is going to be used more for more severe exacerbations, but it has no significant benefit over oral medications. Inhaled steroids or inhaled glucocorticoids, they have no role in acute exacerbation, but they may decrease the exacerbation frequency and improve the symptoms. It doesn't affect mortality or lung function. Long-acting beta-2 agonists, these are used in long-term maintenance. And then you want to consider antibiotics if more than 2 of those cardinal symptoms are present. So that would be like the increase in dyspnea, the cough, or the sputum production. If more than 2 of those are present, then you can give an antibiotic, as well as mechanical ventilation is needed in non-invasive positive pressure ventilation or endotracheal intubation. Sputum cultures isn't recommended unless the patient's at high risk for Pseudomonas infection, and then antibiotics are given to cover common respiratory pathogens like strep pneumoniae, Moraxella catarrhalis, or H. influenza. And you want to include macrolides like azithromycin and fluoroquinolones like levofloxacin and moxifloxacin, as well as a penicillin beta-lactamase inhibitor like amoxicillin clavulanic acid combination. And the duration of that treatment is going to be for 3 to 7 days. And if COPD is associated with formation of blebs, which can rupture and cause spontaneous pneumothorax. Remember that tall, thin, lanky boy? They have increased risk of spontaneous pneumothorax because of the formation of blebs. Pneumothoraxes can be considered in COPD with sudden declines in respiratory function and more acute than acute exacerbations. And then bronchiectasis is not associated with blebs and pneumothoraxes. So let's talk about non-invasive positive pressure ventilation. So what are some of the indications for this? So the strongest evidence suggests that COPD would be an indication, and specifically a severe exacerbation of COPD, and to prevent extubation failure. Another indication for non-invasive positive pressure ventilation would be cardiogenic pulmonary edema, acute respiratory failure, such as a post-operative hypoxemic respiratory failure or in an immunosuppressed patient. And finally, also it facilitates early extubation when you have non-invasive positive pressure ventilations. So indications to facilitate early extubation, you want to give that. Now, contraindications to non-invasive positive pressure ventilations would be either medically, they're unstable, or they have an inability to protect the airway, or there's a mechanical issue. So if there's medical instability like cardiac or respiratory arrest, also severe acidosis if their pH is less than 7.10, acute respiratory distress syndrome, or non-respiratory organ failure like unstable cardiac arrhythmia or hemodynamic instability, as well as encephalopathy like a Glasgow coma score of less than 10 and a GI bleed. Those are medical instability contraindications. Also, the inability to protect the airway, such as if they have if the patient's uncooperative or agitated, or if they have an inability to clear secretions that have a high aspiration risk. And then finally, mechanical issues would be contraindications like recent esophageal anastomosis, facial or neurological surgery, deformity or trauma, as well as upper airway obstruction. Those are contraindications to non-invasive positive pressure ventilation. So non-invasive positive pressure ventilation is a ventilatory support given by face mask rather than endotracheal tube. It's delivered in different methods. So an example here, the universal example, is a CPAP machine and a bi-level positive airway pressure. So this will cause a decrease in the work of breathing. It improves the alveolar ventilation, and it's the preferred method of ventilatory support in patients with an acute exacerbation of COPD. The physiological benefits to a CPAP would be that you decrease the respiratory rate and decrease the CO2, as well as increasing the tidal volume. It increases minute ventilation, and it also increases oxygen. Benefits would be that there's a decreased need of intubation. So if you're on a CPAP or a non-invasive positive pressure ventilation, there's a decreased need to get intubated. It also decreases mortality, decreases any type of treatment failure, and it also decreases the length of hospital stays and the incidences of nosocomial infections. So a trial of non-invasive positive pressure ventilation must be given before an intubation unless contraindications are there, like in a severe COPD, or weaning and extubation will be more challenging. Now that's going to cause failure after 2 hours, a 2-hour trial, causing hypoxemia and acidosis. Then you need to intubate. So oxygen-induced CO2 retention in COPD is the next topic. So supplemental oxygen is going to worsen hypercapnia by the following mechanisms. So at baseline, a decrease in ventilation and a decrease in gas exchange causes vasodilation after you give them oxygen. The effect is that you get a ventilation perfusion mismatch, and that leads to a CO2 retention. Let's say you have low oxygen, so low PaO2, that's going to lead to an increase in CO2 affinity. That's the Haldane effect. Well, after oxygen administration, the PaO2 increases and there's a decrease in CO2 affinity. That decreases CO2 uptake from the tissues, but then can cause CO2 retention. Then you have rapid shallow breathing, which increases your respiratory rate. After you give them oxygen, your respiratory rate goes down, but because it goes down, your minute ventilation also decreases and you get a retention of CO2. So destruction of the terminal bronchioles and the alveoli is going to cause a VQ mismatch, and that's then going to cause local hypoxia and hypercapnia. Because of that, you'll get selective vasoconstriction, which redirects the blood flow to better ventilated areas. So oxygen therapy will then cause vasodilation and an increase in blood flow to affected areas. And then this will then cause the VQ mismatch to worsen, causing an increase in oxyhemoglobin and a decreased uptake from CO2 from tissues by the Haldane effect. So this CO2 retention in COPD is going to decrease the respiratory drive. And because you decrease the respiratory drive, you decrease the respiratory rate. By decreasing the respiratory rate, you decrease minute ventilation. If there's an acute increase in CO2, that's going to lead to an acidosis, and then there's an increase in brain GABA levels and glutamine levels, and there's a decrease in glutamate and aspartate, and that causes a change in the levels of consciousness. Hypercapnia is also going to cause a reflex cerebral vasodilation, and that reflex vasodilation is going to cause seizures. So oxygen should then be given cautiously at a goal with an oxygen saturation of 90 to 93%, or a PaO2 of 60 to 70 millimeters of mercury. So patients who develop significant acidosis have severely reduced levels of consciousness, which requires mechanical ventilation. Next up is going to be bronchiectasis. So clinical features of bronchiectasis, you have signs and symptoms of cough and sputum production that's most that happens most days of the week. Rhinosinusitis as well. They can have dyspnea, hemoptysis, and pleurisy, as well as wheezing, crackles, and digital clubbing. The etiology of bronchiectasis is that an airway obstruction, a congenital cause like cystic fibrosis or alpha-1 antitrypsin deficiency, immunodeficiencies like hypogammaglobulinemia, post-infectious causes like aspergillus, viral infections, TB, rheumatic and systemic diseases like rheumatoid arthritis and Sjogren's syndrome, as well as toxic inhalation aspirations. The evaluation of bronchiectasis is that you want to do a CBC with a differential, as well as immunoglobulin quantification, sputum culture and smear for bacteria, for funguses and TB. You want to also get a high resolution CT and pulmonary function tests as well. So how do they come in? The clinical features of bronchiectasis is you get a very productive mucopurulent sputum that's more than 100 milliliters a day, and this is going to cause recurrent fever, fatigue, weight loss. There could be rhonchi or wheezing and crackles that are more common in bronchiectasis than in COPD. In COPD, that's more common in smokers and in bronchiectasis patients which have a history of recurrent respiratory infections. A chest x-ray is not sensitive or specific for the diagnosis of bronchiectasis. So it'll cause linear atelectasis with dilated and thickened airways and irregular peripheral opacities. So how would you confirm is with the high resolution CT scan. That's going to show bronchial dilation, airway thickening, and a lack of airway tapering. And that's going to basically confirm that and the way you confirm it is with a sputum analysis for bacteria and mycobacteria like TB or atypical infections. And in all patients, you want to do a bronchoscopy. And the reason why you do that is for focal diseases to evaluate for a localized airway obstruction. You can also rule out systemic disease for diffuse involvement, and you want to treat that etiology with steroids and macrolides for inflammation. Pharmacological agents and chest physiotherapy is done to mobilize those airway secretions, and the exacerbation is then going to be treated with specific antibiotics that are tailored to whatever results you get on microbiology. Surgical resection and transplant may also be needed if the cases are very severe. The reason why you do PFTs is that you want to monitor that progression of the disease. It's not really for the diagnosis, it's just to see if the medications that you're giving them is actually working or not. And in contrast to a chronic bronchitis, which presents with non-purulent expectorization, so a chest x-ray here is usually normal. All right, so next topic is asthma. So first of all, we're going to talk about the types and the treatments of asthma. So there's 4 types of asthmas based on the severity. And here they're mild intermittent, mild persistent, moderate persistent, and severe persistent. Those are their 4 types of asthma. So in mild intermittent asthma, symptoms are usually less than 2 days a week. They cause nighttime awakenings less than twice a month. And you'll need to use beta agonists less than 2 times a week. The FEV1 FVC ratio is usually normal, and there's no limitation on daily activities. And the treatment for mild intermittent asthma would be a short-acting beta agonist like albuterol, and you do that as needed, and there's no need for a daily controller of medications. It's just PRN basically as needed, albuterol. That was mild intermittent. Now mild persistent is these symptoms are going to be occurring more frequently, so more than 2 days a week, but less than daily. So it's not happening daily, it's just happening more than 2 days a week. It's also the nighttime awakenings are happening 3 to 4 times a month. The FEV1 FVC ratio still remains normal. And then you'll start to notice that there are mild limitations of daily activities in these patients. And the treatment here is that you want to continue with their short-acting beta agonist like albuterol, but you want to add a low-dose inhaled steroid to control as a controller medication. So one thing in common of all these is that as you go up from mild intermittent to mild persistent to moderate persistent to severe persistent, you're adding medications. So it's not like before you took albuterol, now you don't. No, albuterol is always going to be needed in every single type of asthma. You're just going to be adding a medication, and adding a medication as the symptoms get worse. So that makes it a little bit easier to understand. So next is going to be moderate persistent, and these are when you have daily symptoms, you have weekly nighttime awakenings, and your FEV1 FVC is 60 to 80% predicted, so it starts declining. Here you're going to continue on with your albuterol, but you want to add a low dose inhaled steroid like we had in mild persistent. So albuterol, the low dose inhaled steroid, and here you also want to add a long-acting beta-2 agonist inhaler. Okay, so the next one is finally severe persistent, and these are that the symptoms are happening throughout the day. Not just every day, it's happening many times in one day. Also, you get frequent nighttime awakenings, and the FEV1 FVC ratio has actually gone down less than 60%. And on activity, they have very extremely limited activities. The treatment here would be, again, albuterol as needed, a long-acting steroid, a high-dose inhaled steroid, and an oral steroid like prednisone. And that's it. So it's mild intermittent, mild persistent, moderate persistent, and severe persistent. So how do you make the diagnosis of asthma? You make it with the pulmonary function test and spirometry to assess for a bronchodilator response. If there's no response, then you just have to check a methacholine challenge test. There could be nocturnal or early morning peak expiratory flow rate measurements, and for those with nocturnal symptoms only. Alternative approaches would be 2 to 4 times a week. So you want to treat 2 to 4 times a week with inhaled steroids. And if the symptoms improve, then asthma is then finally diagnosed. So asthma and comorbid GERD. So comorbid GERD is usually present in patients with asthma, and that's a microaspiration of the gastric contents. It's going to increase the vagal tone and bronchial reactivity, and it's going to exacerbate asthma symptoms because the gastric contents are irritating. So that's going to stimulate asthma symptoms. So that will be like a sore throat and morning hoarseness because of that laryngeal nerve being irritated. There's an increase in cough only at night, and there's an increased need for albuterol inhaler after meals. It's not associated with typical GERD symptoms, and there's an increased risk with obesity. And the treatment here is that you just want to add PPIs to improve the asthma symptoms and peak expiratory flow rates in the asthma patients. Now, there's another one called aspirin-induced asthma, and that's a non-IgE mediated form of asthma. It can develop asthma, can also develop chronic rhinosinusitis, as well with nasal polyposis and chronic urticarial patients. And the symptoms are sudden worsening of the asthma, like coughing and wheezing and chest tightness, as well as nasal or ocular symptoms like nasal congestion, rhinorrhea, and periorbital edema, and then facial flushing within 30 minutes to 3 hours after the ingestion of NSAIDs. The treatment here is to manage the underlying asthma and the nasal congestion and avoid NSAIDs or desensitization to NSAIDs if the use is required. Leukotriene inhibitors like xyleutin and leukotriene receptor blockers like montelukast can also improve nasal and respiratory symptoms. So what are some of the indications of severe acute asthma exacerbation? That would be an acute pulmonary insult such as an acute exacerbation of asthma. That's going to increase the respiratory drive due to a combination of hypoxemia and anxiety due to a sensation of the dyspnea and signals from the thoracic neural receptors due to a change in lung volume and in the presence of inflammatory chemicals like prostaglandins and histamines. And because of that, you get hyperventilation. Hyperventilation is going to lead to a decrease in CO2. It's also going to give you a respiratory alkalosis. A normal pH and a normal PaCO2 indicates the inability to maintain adequate ventilation in the settings of increased works of breathing, and that's caused by respiratory muscle fatigue and severe air trapping, which is then finally going to suggest an impending respiratory collapse or respiratory failure. Other signs of impending respiratory failure would be markedly decreased breath sounds. There could be absent wheezing, as well as altered mental status. Marked hypoxia with cyanosis. All right, so next is the treatment of an asthma exacerbation. How would you treat that? Mild to moderate exacerbation is treated with oxygen and inhaled short-acting beta-2 adrenergic agonists. They usually respond to that, but if they don't respond, then you have to give them systemic steroids. Severe exacerbations, you want to give them a SABA, the short-acting beta-2 agonists. And if no improvement after an hour of therapy, and that therapy was nebulizers with systemic steroids, then you do a one-time dosing of IV magnesium sulfate, which is going to cause bronchodilation. And if there is if there's still signs of respiratory failure, you want to admit them to the ICU with an endotracheal intubation. All right, so now asthma versus COPD. So in asthma, the FVC is normal, or it could be decreased. The FEV1 is decreased, and the FEV1 FVC is also decreased. So this is pretty much the same as in COPD. But here, when you have bronchodilators given in asthma, the symptoms are reversible, versus in COPD, they're non-reversible, or they could be a little bit partially reversible, but it's mainly non-reversible. So that's a clue right there. Then in a chest x-ray, that's not really going to tell you much. They're both going to look the same. And the DLCO, they can both be normal, or in asthma it could be increased, because remember the DLCO is the diffusion limitation of carbon monoxide, versus in COPD you have a diffusion limitation there, so it'll be decreased. Now, what about the late stage COPD? In late stage COPD, then the only difference here is that the chest x-ray, instead of being normal, you'll see hyperinflation. You'll see loss of lung markings. These are the ones that are obviously going to be given on the exam. They'll show a huge lung that's flat and is going to cause flattening of the diaphragm. So it'll be a later stage COPD. And the DLCO is going to be decreased. So that's the only difference between COPD and late onset or late stage COPD, is that the chest X-ray and the DLCO is going to be decreased. All right, so asthma is usually going to be diagnosed in childhood or young adulthood, but it can develop in adults. It's hard to clinically differentiate COPD and adult onset asthma, especially if they're smokers. The pulmonary function tests are usually needed in that case. Bronchodilators, usually like albuterol, followed by spirometry, is the most effective test, and they're going to be differentiating the asthma and the COPD. Remember, in asthma, will react to bronchodilators, and COPD they won't. So there's a normal airflow after bronchodilator use. That rules out COPD. Positive bronchodilator response means that there's a more than 12% increase in FEV1, and that's seen in asthmatics. COPD never shows complete response to bronchodilators, and the DLCO is never increased in COPD. In COPD and asthma must be differentiated, because COPD can mainly be treated by long-acting anticholinergic inhalers, and asthma is basically treated with long-term steroids, so two completely different medications. Next up is Theophylline toxicity. Theophylline is due to a decrease in the clearance of the drug, causing a decreased metabolism by cytochrome oxidase. This is due to the inhibition of those enzymes by concurrent illnesses like cirrhosis or cholestasis, respiratory infections with fevers, or drugs like cimetidine or ciprofloxacin, erythromycin, clarithromycin, or verapamil. And the symptoms here would be CNS stimulation effects like headaches, insomnia, seizures, GI disturbances like nausea and vomiting, and cardiac symptoms like arrhythmias. Okay, next up is your restrictive lung diseases. So restrictive lung diseases, we're going to start off with interstitial lung disease. So common etiologies of interstitial lung diseases would be like sarcoidosis, amyloidosis, alveolar proteinosis, vasculitis as well can give you interstitial lung diseases like granulomatosis with polyangiitis, that's Wegener's. Infections like fungal or tuberculosis or viral pneumonias can also cause interstitial lung disease. Occupational and environmental agents like silicosis or hypersensitivity pneumonitis. Also connective tissue diseases like lupus or scleroderma, and as well as idiopathic pulmonary fibrosis and interstitial pneumonia, and cryptogenic organizing pneumonias as well. So clinically, how do they present with interstitial lung disease? Is a progressive exertional dyspnea or a persistent dry cough. Pulmonary findings are going to be due to other underlying conditions like silicosis or connective tissue disease, and more than 50% of patients with significant smoking history. On lung examination, they're going to have fine crackles during mid to late inspiration, and they could possibly have digital clubbing as well. On labs or imaging on chest x-ray, you can see reticulonodular opacities in the lungs. On a high resolution CT, it usually is going to show fibrosis or honeycombing of the lungs, and there could be a traction bronchiectasis as well. Pulmonary function tests are usually normal, or the FEV1 FVC ratio can be increased, a decrease in the DLCO, a decrease in the total lung capacity, and there could be a decrease in the residual volume. In resting arterial blood gas can be normal, or it can show mild hypoxemia. Exertion is usually causes significant hypoxemia due to a VQ mismatch. And the diagnosis is clinical. PFTs and imaging are done, but biopsy may be needed if the case is unclear whether or not they have an interstitial lung disease or not. So in idiopathic pulmonary fibrosis is an extracellular matrix around the alveoli, and that causes scarring. That scarring is going to lead to a decrease in total lung capacity. There's a decrease in functional residual capacity, a decrease in residual volume, and an increase in elastic recoil. All of this is going to cause an impairment in gas exchange. It's going to cause a VQ mismatch, and it's also going to increase the AA gradient in all patients. Remember that AA gradient is going to increase in restrictive lung diseases in all patients, and then resting arterial blood gases could be normal. So hypersensitivity pneumonitis, this is a form of interstitial lung disease, is an inflammation of the lung parenchyma, and that's caused by antigen exposure. So common responsible antigens here would be like aerosolized bird droppings. So somebody who works with birds can have this, as well as mold associated with farming. That's your farmer's lung. Acute episodes are within 4 to 6 hours of the exposure. There's fever, there's cough, breathlessness, and malaise. And chronic exposure is going to have weight loss associated with it, as well as clubbing in your digits, pulmonary fibrosis leading to a restrictive pattern on spirometry. And on chest x-ray, you have the ground glass opacities, or that haziness of the lower lung fields. That's also known as honeycombing. The best treatment here is to avoid being around birds, because the birds are the problem. Get away from the birds. This can produce complete remission. Systemic steroids speed up the recovery of acute symptoms and essential parts of the management of severe episodes, but do not slow or reverse progression. In asbestosis, the clinical features of asbestosis are a prolonged asbestosis exposure, like if they're shipyard workers or miners or construction workers or pipe fitters. Any of those jobs on the vignette, start thinking of interstitial lung diseases, specifically asbestosis. Symptoms develop more than 20 years after the initial exposure. There's progressive dyspnea over the months, and bibasilar and inspiratory fine crackles and clubbing as well. There's an increased risk for malignancies like lung cancer and malignant mesothelioma. So how would you diagnose asbestosis? With a history and physical clinical findings of exposures, you'll see pleural plaques on chest x-rays or chest imaging, and that's basically pathognomonic, the pleural plaques. Interstitial fibrosis on imaging or a histology, or it could have pulmonary function tests with a restrictive pattern. And you also exclude other diseases. So asbestosis exposure is also very common in plumbers and electricians and carpenters, insulation workers, because asbestos fibers were used to as a form of insulation. Asbestosis and bronchiogenic cancer can present similarly. Interesting enough, old race car drivers, because race cars back in the 60s and 70s, earlier than that too, the brake calipers were made of asbestos because of the good insulation of heat that they produced. So because of that, a lot of the drivers that were immediately behind the brakes, since they have no fenders and they're just exposed to the elements, they would be constantly inhaling these asbestos fibers. So there's a lot of famous race car drivers that died because of mesothelioma or asbestos, and that could be, I don't know if that could be a vignette question, but it could be a definite question if they wanted to. Asbestos and bronchiogenic cancer can present similarly, and other findings on chest x-rays are bibasilar reticulonodular infiltrates such as honeycombing and cystic areas that are surrounded by interstitial infiltrates, as well as bilateral pleural thickening. There also could be subpleural lining densities and parenchymal fibrosis and on the high resolution CT scan, and the images can also show signs of bronchogenic cancer. So let's talk about DLCO again. This is a differential diagnosis based on carbon monoxide diffusion capacity of the lungs. So a low DLCO, a normal DLCO, or an increase in DLCO. So emphysema, this is a low DLCO. It shows an obstructive pattern, so the FEV1 FVC is going to be less than 70%. A normal DLCO with an obstructive pattern is going to be like chronic bronchitis or asthma, and an increase in DLCO, but that shows an obstructive pattern, is asthma. A restrictive pattern with a low DLCO is interstitial lung diseases, sarcoidosis, asbestosis, or heart failure. A normal DLCO, but they have a restrictive pattern, would be like musculoskeletal deformities or neuromuscular diseases. And then an increase in DLCO with a restrictive pattern would be morbid obesity. And what if they have a normal spirometry but a low DLCO? That would be anemia or a pulmonary embolism or pulmonary hypertension. But if their DLCO is increased but spirometry is normal, that would probably be more of a pulmonary hemorrhage or a polycythemia. So a normal DLCO means that there's an intact capillary and alveolar structures. Next up is pulmonary hypertension. Pulmonary hypertension is defined as a pulmonary arterial pressure that's more than 25 millimeters of mercury at rest and more than 30 millimeters of mercury at exertion. Pulmonary hemangiomatosis, which is a disorder directly affecting the pulmonary vasculature, can also cause pulmonary hypertension, and those symptoms are dyspnea, weakness, and fatigue, and later on it can progress to chest pain, hemoptysis, syncope, or hoarseness. because of the laryngeal nerve involvement. Signs of right heart failure are going to develop later on in the disease, and that will cause a cor pulmonale. And on physical exam, you'll see clear lung fields, but they'll have crackles in pulmonary fibrosis. On chest x-ray, there could be enlargement of the pulmonary arteries with rapid tapering off of distal vessels. That's also known as pruning, and there's an enlarged right ventricle. Cor pulmonale is our next topic, and characteristic findings of cor pulmonale would be COPD is the most common etiology of cor pulmonale, interstitial lung disease, pulmonary vascular diseases like thromboembolic diseases, and obstructive sleep apnea. Symptoms of cor pulmonale would be dyspnea on exertion, fatigue, lethargy. There could be exertional syncope due to a decrease in cardiac output, as well as an exertional angina, which is due to an increase in myocardial demand. On exam for cor pulmonale, they'll have peripheral edema, an increase in jugular venous pressure with prominent A waves. There's a loud S2. There could be a right-sided heave, a pulsatile liver from congestion, that's called cardiac cirrhosis, maybe, and tricuspid regurgitation. So everything's going on the right side of the heart and backing up. So on imaging, on EKG, there's a partial or a complete right bundle branch block. There could be right axis deviation, right ventricular hypertrophy, and right atrial enlargement. On echocardiogram, there could be a pulmonary hypertension, there could be dilated right ventricles, or a tricuspid regurg. And on right heart catheterization, that's the gold standard for the diagnosis. It's going to show right ventricular dysfunction, pulmonary hypertension, and no left heart disease. So cor pulmonale usually develops gradually, but it can be acute in onset in cases of pulmonary embolisms. COPD patients have distant heart sounds due to the hyperinflation of the lungs. Cardiac tamponade also has distant heart sounds, but it's more acute. And COPD is chronic. End-stage cor pulmonale is going to present with hypotension, tachycardia, and signs of cardiogenic shock due to a decrease in stroke volume. On chest x-ray, there can be a central pulmonary artery enlargement and loss of retrosternal airspace due to right ventricular enlargement. On right heart cath, that's going to show an increase in central venous pressure. There could be right ventricular end diastolic pressure and a mean pulmonary arterial pressure of more than 25 millimeters of mercury without left heart disease. So if you have those kind of increasing in pressures on the right, but nothing's going on the left, there's a pulmonary problem going on there that's backing up into the heart. That's cor pulmonale. So the treatment is optimization of the right heart dynamics. So you got to optimize preload, afterload, and you got to optimize the contractility of the heart with supplemental oxygen. You can do it with diuretics, and you want to treat any kind of underlying etiology and IV inotropes for severe decompensation. So pleural effusions, common causes of pleural effusions are your transidates and exudates. This is a common form of pleural effusions. So transidates would be congestive heart failure, cirrhosis, nephrotic syndrome, and peritoneal dialysis. The more common is the CHF, the cirrhosis, and the nephrotic syndrome. If you can just remember those three, then all the other ones are going to cause exudative effusions, right? So transidative is nephrotic, cirrhotic, and CHF. Remember that. Everything else is exudates. So what are the exudates? Infections, malignancies like lung cancer, breast cancer, lymphomas, malignant pleural effusions, connective tissue diseases, inflammatory disorders, movement of fluid from the abdomen into the pleural space, coronary artery bypass surgery, pulmonary embolisms, which is usually the case of exudative effusions. All those are exudative. And transidates are just nephrotic, cirrhotic, and CHF. It's as easy as that. When the pleural effusion is suspected or is diagnosed, then the first step is to determine the cause of the pleural effusion and management starts with whether it's a transudate or whether it's an exudate. So the first step is that you want to do a diagnostic thoracocentesis, and you want to do that bedside because it's minimally invasive and it permits a rapid sampling quantification as well as microscopic examination and visualization. So it's a perfect test. It provides decision-making information in 90% of the cases. However, if patients have established a cardiogenic edema, then a trial diuretic can be started. If there's an unclear cytology and there's a lung mass present, then you want to do a bronchoscopy. If the cytology shows malignant cells, then there's no need to do a bronchoscopy. It's because of the malignancy. Light's criteria for pleural effusion. So Light's criteria is going to tell you whether it's a transudate or exudate, going in terms of whether the levels of protein, LDH, and that's it. So protein or LDH. So in transudative effusions, remember cirrhosis, nephrosis, and CHF is going to be a pleural serum protein of less than 0.5, and the LDH in the pleura or the serum, the ratio is going to be less than 0.6. The pleural LDH is going to be less than 2/3 the upper limit of normal serum LDH. And the common causes of transudative effusions, we already said that: cirrhosis, nephrosis, congestive heart failure, hypoalbuminemia. But exudative is going to be different. I had trouble remembering these two because they're just numbers that you need to memorize. So exudative means excessive. So the first two letters, exudative, excessive, exudative. So excessive meaning that the protein pleural serum ratio is excessively over 0.5. The LDH pleural to serum ratio is excessively over 0.6. So if it's more than 0.6 in the LDH, more than 0.5 protein, it's exudative. So it's anything other than CHF, nephrosis, and nephrotic, cirrhotic, and CHF. So then common causes of exudative, we said it's infections, parapneumonic infections, TB, fungal infections, empyema, malignancy, and pulmonary embolism. All right, so a normal pleural pH is 7.6. A transudative pH is 7.4 to 7.5, and there's no need for further intervention except for the treatment of the underlying disease. An exudative pH due to inflammation is going to be 7.3 to 7.45, and a pH that's less than 7.3 is usually due to excessive acid production by pleural fluid cells and bacteria such as empyemas, or a decrease in hydrogen ion efflux from the pleural space like pleuritis, pleural fibrosis, or tumors. Exudative effusions are due to inflammation. That exudative effusions is excessive because you have an excessive release of cytokines. This is going to cause an increase in capillary permeability. Glucose levels are going to be less than 60 milligrams. That's usually due to rheumatoid pleurisy, lupus pleurisy, esophageal rupture, and causes mentioned beforehand. There's less than 30 milligrams of glucose is almost always due to an empyema or a rheumatic effusion, and pancreatitis and esophageal rupture causes an increase in amylase in pleural fluid. So it's pretty easy to remember that way. Pancreatitis, you're going to have high amylases in the pleural fluid, obviously, because you're secreting all that pancreatic enzyme. And glucose levels are going to be less than 60 because there's so much bacteria that it's eating up all the glucose. Same as for bacterial meningitis. You have low glucose levels because the bacteria are eating up all the glucose. Now, transudative has a decrease in pleural pressure, there's a decrease in plasma oncotic pressure, and there's an increase in hydrostatic pressure. Remember, we said that transudative were nephrotic, cirrhotic, CHF. All these are going to be causes of low protein levels. And when you have low protein levels, your oncotic pressure is going to be decreased. And because your oncotic pressure is decreased, then by default, the opposite hydrostatic pressure is going to be increased. And in the liver, cirrhosis is going to cause an increased permeability of the right hemidiaphragm, and that's going to lead to a right-sided pleural effusion known as a hepatic hydrothorax. And that's easy to remember also because the liver is right next to the right lung. So it's obvious that it's just going to diffuse right in there. In CHF, it can meet exudative criteria in 25% of patients who have received excessive diuretic therapy prior to thoracocentesis. They're mostly bilateral 61% of the time, and it can be unilateral on the right side in 27% of cases, and on the left side, 12% of the cases. Remember that liver being the cause of it more commonly on the right. In a TB effusion, that's an exudative effusion, that's moderate pleural lymphocytosis with a very high levels of proteins, because bacteria don't care about proteins, they want glucose. So proteins are high. Chronic kidney disease, diabetes mellitus, and smoking all increase the risks of reactivation of TB. And a malignant pleural effusion is also exudative, but they do have lymphocytosis because lymphomas, basically, malignant pleural effusion, lymphocytosis more than 70%, and it's uncommon though. Trauma or malignancy causes a disruption in the thoracic duct, and that leads to a chylothorax, which is exudative. It's high in cholesterol content and milky white in appearance. There's no fever, chest pain, because the chyle itself doesn't induce inflammation. Remember, what induces inflammation are cytokines. All right. Next up, we have pneumonias. Pneumonias can either be classified into a lot of pneumonias, community acquired. So let's start off with community acquired pneumonia, which is the most common organisms for community acquired pneumonia, meaning that you got the pneumonia outside of the hospital, is strep pneumo, Haemophilus influenzas, and all your atypicals like mycoplasma. Patients are required ICU admission, usually have other organisms like Staph aureus and Legionella, and gram-negative organisms like Pseudomonas. And the first step in treatment is to do a risk assessment to know whether or not the patient can be treated as an outpatient or as an inpatient. Cardiopulmonary conditions are going to be age, severity of symptoms, and the effect risk for a community-acquired pneumonia. So what is that risk? And that's measured by the CURB 65 criteria. And that is also known as confusion, or is abbreviated as confusion, uremia, with a blood urea nitrogen levels of more than 20, BUN greater than 20, tachypnea, more than 30 breaths per minute, hypotension, so your blood pressure less than 90 over 60, and age is greater than 65. So if you have a score of more than 2, then that requires hospital admission. But if the score is more than 4, then that goes straight into ICU admission. So community-acquired pneumonia settings. So the outpatient settings, the recommended therapy for an outpatient community-acquired pneumonia in healthy patients would be macrolides or doxycycline. And for comorbid conditions like diabetes and malignancy, you want to give them fluoroquinolones or a beta-lactam with a macrolide. For an inpatient community-acquired pneumonia therapy or non-ICU is a fluoroquinolone or a beta-lactam with a macrolide. And in the inpatient ICU, they start off with a beta-lactam and a macrolide, or a beta-lactam and a fluoroquinolone. But beta-lactams are given first for ICUs. Parapneumonic effusions can be divided into complicated, uncomplicated, and empyemas. So the etiologies of uncomplicated parapneumonic effusion is that it's a movement of fluid from the pneumonia into the visceral pleura. The pleural fluid analysis is going to be a pH greater than 7.2 and a decrease to normal amounts of glucose. The LDH ratio is more than 0.6, and the pleural fluid gram stain is going to be negative. The pleural fluid culture is negative, and the treatment is to give them antibiotics. Now, for complicated parapneumonic effusions, these are usually caused from persistent bacterial invasions into the pleural fluid. So in uncomplicated, that was just movement of fluid from the pneumonia into the pleura. Here it's bacterial invasion into the pleura. So you can see why that becomes more complicated. Pleural fluid analysis is a pH that's acidotic, less than 7.20, and a decrease in glucose, LDH ratio of more than 0.6. Again, because bacteria love sugar. The pleural fluid gram stain is going to be negative, and the pleural fluid culture is also negative. But the treatment here is to also give antibiotics, and that usually requires a chest tube drainage because it's complicated. For an empyema, which is a pleuritic chest pain with a productive green phlegmy cough and fever, this would be bacterial colonizations of the pleural fluid, and a purulent fluid at that. So because of that, again, you'll have an acidic pH in the pleural fluid, so less than 7.2, low glucose, and the LDH ratio is going to be more than 0.6. Remember, empyemas were exudative, right? Positive fluid gram stain, because in an empyema, there's a loculated pleural effusion on the chest x-ray with pus on the paracentesis, unlike in complicated. So in complicated, there is no pus or there's no pus, and it's but here in an empyema it is. There is a positive pleural fluid gram stain, and the culture is also positive usually, and antibiotics with chest tube drainage is going to be the treatment, and the antibiotics are usually given for 2 to 4 weeks, and that's it. So pneumonias start off with shortness of breath and low-grade fever. So a way that I always remember pneumonia is fever and a cough. Any vignette you get, fever and a cough, that's pneumonia until proven otherwise. Fever and a cough. Guy comes in, he has a fever, blah, 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 also had a cough, blah, blah, blah. Okay, this is pneumonia, buddy. So that is the best way to remember it, a fever and a cough. 40% of cases are associated with parapneumonic effusions, like a pleural effusion, and it's usually exudative by the Light's criteria, like we said before. Pleural fluid protein to serum protein ratios are going to be excessive, more than 0.5, due to an increase in microvascular permeability and cellular destruction. The fluid lactate dehydrogenase, or LDH, level is also excessive at more than 0.6. And the pleural fluid LDH is more than 2/3 the upper limit of normal for a serum LDH of, let's say, 2/3 normal times 90 equals 60, and 60 is the upper limit of normal. So a low pH is due to anaerobic utilization of glucose by neutrophils and bacteria. And then finally, the low glucose is due to consumption by activated neutrophils and bacteria. Remember, bacteria love sugar, so levels of glucose will be low. They mostly are uncomplicated, small, sterile, free-flowing, and basically they do resolve with antibiotics. And in immunocompromised patients, they're at higher risk for pneumonia complications. Something to remember is that drug-induced lupus can cause an exudative effusion with a low pH and glucose levels of less than 60, but here it's with drugs like hydralazine, procainamide, and isoniazid. Remember, those are the drugs that cause drug-induced lupus, and drug-induced lupus here can give you an exudative effusion. Remember, anything that's not nephrotic, cirrhotic, or CHF is exudative. All right, pulmonary embolism is a common cause of an exudative and a transudative pleural effusion, unfortunately. So that's the gray area there, pulmonary embolisms. It could be either exudative or transudative. It could have bloody pleural effusions, but it does not cause any types of changes in pH or in glucose. So there's no low pH or low glucose. Then there's a VQ mismatch in pneumonia. So the alveoli in the affected segment is going to become filled with exudative material and cellular debris. And that alveoli is going to then cause, because of all that material and debris, is going to cause consolidation. That's going to lead to a decrease in ventilation and normal perfusion with a very low VQ. The lung bases have the highest ventilation and perfusion, and the apexes have the least amount of ventilation and perfusion due to gravity, right? So assuming the lateral position will increase blood flow to ventilated areas on the dependent side, if the position is lateral, opposite to that of the consolidation, then oxygenation will increase because more blood will flow to the normal side. And if the position of the consolidation is assumed to be on the opposite side, then there's an increase in blood to that effective side and a decrease of flow to the normal side, and that then causes hypoxemia because of the physiological shunting. So what did I just say? Basically, if somebody presents with a consolidated lung because of exudation or whatever, any kind of consolidation in the lung, and they're having difficulty breathing because they're laying down or whatever, where would you like to lay the patient? Do you want to lay him on the consolidated part or on the normal part? And you want to lay him down on the lung that has the consolidation, because then by default all the air will go up, and that's where you have the greatest ventilation and perfusion. All right, next up is causes of recurrent pneumonia. So causes of recurrent pneumonia are involving either the same region of the lung or different regions of the lung. So if it involves the same region of the lung, then it's due to local anatomic obstruction, like a bronchial compression or a neoplasm. There can be a mediastinal adenopathies or vascular abnormalities, as well as intrinsic bronchial obstructions like bronchiectasis and retained foreign bodies and bronchial stenosis. Those are all local anatomic obstructions versus recurrent aspirations that can also be a cause of recurrent pneumonia that affects the same region of the lung. These recurrent aspirations, like seizures, can give you recurrent aspirations, ethanol or drug use, as well as gastroesophageal reflux disease, dysphagia, or achalasia. Now, if it involves different regions of the lungs, causes of recurrent pneumonias would be like sinopulmonary diseases like cystic fibrosis, emodal cilia, like in Cartaginer syndrome, maybe non-infectious like vasculitis causes, bronchiolitis, obliterans, and organizing pneumonia. Also immunodeficiencies like HIV and leukemia, also a decrease in immunoglobulins can all give you recurrent pneumonias in different parts of the lung. The most important cause involving the same region of the lung is going to be bronchogenic carcinoma. Carcinoid is usually endobronchial and can also be the cause. And a CT is indicated to look for underlying parenchymal diseases like a mass, and if that's the case, then you want to do a bronchoscopy. If there's a negative CT, then and you have a high suspicion of endobronchial obstruction, you want to go ahead and do a bronchoscopy. If there's a central mass on CT, you also want to do a bronchoscopy. And if there's a peripheral mass on the CT, then you want to do a CT guided biopsy. So basically, if it's on the periphery of the lung, that's easily surgically located, so you can just CT guide it and do a biopsy that way. But if it's in the middle, like a central mass, then you got to go through bronchoscopy. Next up is aspiration pneumonia. And predisposing conditions for aspiration pneumonia would be like altered consciousness, impairing cough reflex, and the glottic closures, like dementias and drug intoxications. Also dysphasias due to neurological deficits like strokes and neurodegenerative diseases. Those are all predisposition conditions of aspiration pneumonia. Others are upper GI tract disorders like GERD, mechanical compromise of aspiration defenses like nasogastric and endotracheal tubes, protracted vomiting and large volume tube feedings in the recombinant position. Aspiration syndromes, you got your pneumonia and you have your pneumonitis. For pneumonia, here is the lung parenchyma has an infection. There's aspiration of the oral cavity causing microbes to enter the lung when they get pneumonia through aspiration. Clinical features of pneumonia would be present days after the aspiration event, fever, cough with an increase in sputum. On chest x-ray, there'll be an infiltrate in the dependent lung segment, and that's classically the right lower lobe. And it can progress to having an abscess. And the management for pneumonia is antibiotics, so clindamycin or beta-lactam antibiotics or beta-lactamase inhibitors. Versus pneumonitis, here we have inflammation of the lung parenchyma. It's not necessarily an infection, this is due to an inflammation. It's an itis, pneumonitis. It's an aspiration of gastric contents as well, but here the injury is due to the subsequent acid that's irritating the area, causing inflammation. Clinical features would present hours after the aspiration event versus days in pneumonia. And in pneumonitis, the range is from no symptoms to non-productive cough to a decrease in oxygen, and then finally respiratory distress. And on chest x-ray, there'll be infiltrates, and those infiltrates can be either one or both of the lower lobes, and that can resolve without antibiotics. It usually resolves rapidly within 24 to 48 hours. And the management is supportive. There's no antibiotics required because it's not an infection, it's an inflammation. ARDS will typically involve the entire lung fields, and it's not specifically the lower lung fields. Okay, moving on. And then finally, it can be a complication of a positive pressure ventilation that can also cause hypotension and alveolar damage, especially in patients with ARDS, pneumonia, and obstructive airway disease. So let's say you have a solitary pulmonary nodule. So that's our next topic, solitary pulmonary nodules. So if you see it on x-ray, a solitary pulmonary nodule, then the first thing you want to do is check a previous x-ray, check an old x-ray. If you have seen, if there was a stable lesion that's been there for over 2 to 3 years, it hasn't really changed, then no further testing is required. However, if there's no previous imaging and you see a possibility of that nodule growth to occur, then you want to do a chest CT. And with the chest CT, it's either going to give you benign features, suspicious, intermediate suspicious features for malignancy, or highly suspicious features for malignancy. So if it's benign, so it has benign features, then you want to keep doing serial CT scans and make sure that nodule is under control. If there's intermediate or suspiciousness for malignancy, then you want to further investigate that nodule with a biopsy or with a PET scan. And the percutaneous biopsy is going to be preferred. Bronchoscopy is not as sensitive as a percutaneous biopsy unless the lesion is more than 2 centimeters big. Now, if on CT you see high suspicious for malignancy, then you want to surgically excise it. All right, so let's say you have that solitary pulmonary nodule, and it's high malignancy risk. We said that you surgically excise it. But if you have a low or intermediate malignancy risk, you also want to check the nodule size, because this is the further investigation part of it with a biopsy or a PET scan. So with that, you want to check the nodule size. If the nodule is more than 8 millimeters big, then you want to do a 18-fluorodeoxyglucose positron emission tomography, or a FDG-PET. You want to do that, or a biopsy. And if with that you have suspiciousness for malignancy, again, you surgically excise it. You don't need to know that FDG-PET is, but all you got to know is that if whatever shows up as suspicious for malignancy, then you want to surgically excise it. However, if it's not suspicious for malignancy, then you want to just go ahead and make sure you're keeping an eye on that lung nodule with serial CT scans. Now, if the nodule size on the intermediate malignancy risk is less than 8 millimeters, then you have to subclassify that if it's either less than 4 millimeters or between 5 to 7 millimeters. If it's between 5 to 7 millimeters, then you want a serial CT scan, but if it's less than 4 millimeters, that's a malignancy risk. So at that point, if it's a malignancy risk but it's small, you got to ask yourself, is the malignancy risk low or is it intermediate? If it's an intermediate malignancy risk, you want to do the serial CT scans. This is where it gets confusing. The reason why you do serial CT scans is because the size of the nodule is still small at less than 4 millimeters. However, if it was more than 8 millimeters, that's when you surgically excise it if you had suspicious for malignancy. But if it's less than 4 millimeters and there's malignancy risks there, you want to do serial CT scans, and at that point you can tailor the treatment there, so you can constantly see it getting bigger and bigger until the point where it's a little bit more than 8 millimeters, then you can surgically excise it. But however, if the malignancy risk is low and it's less than 4 millimeters, there's nothing, you don't have to do anything, no follow-up is needed. So the definition of a solitary pulmonary nodule is defined by 4 things. So it's defined by rounded opacity. It's defined as it's less than 3 centimeters if it's completely surrounded by pulmonary parenchyma, and that there's no associated lymph node enlargements, pleural effusions, or atelectasis. So ground glass lesions are going to have a higher risk for malignancy, and they likely require a yearly assessment, even with stable appearance and the size. So the assessment of malignancy risk in a solitary pulmonary nodule is variable. So with that in mind, we're going to see if it's either what to do with low risks, intermediate risks, or high risks. Remember, low risks, the nodule size are less than 0.8 centimeters. They occur at less than 40 years of age in patients who have never smoked, or they have stopped smoking over 15 years ago. So it's been 15 years since their last cigarette. And the nodule margins are smoothed. But intermediate risks would be in between 0.8 centimeters to 2 centimeters. It affects patients between the ages of 40 to 60. They are currently smoking, or they stopped smoking less than 15 years ago. So between 5 to 15 years. And the nodule margins are going to be scalloped. High risk for solitary pulmonary nodule being a malignant feature, that means that the size is big, so it's more than 2 centimeters. It affects patients older than 60. They are currently smoking, and they quit smoking less than 5 years ago. And the nodule margin characteristics, that they have a corona radiata or a spiculated nodule. So if you see spiculated, that's a malignant feature. Causes of solitary pulmonary nodules: primary lung cancer is a cause, metastatic cancer, benign infectious granulomas, benign neoplasms, and vascular causes. So under primary lung cancers, for solitary pulmonary nodule, you have your squamous cell carcinoma, adenocarcinoma, small cell carcinoma, and you also have large cell and carcinoid. Metastatic cancers like melanoma, breast cancer, head and neck cancers, renal cell cancer, colon cancer, germ cell cancers, and sarcomas are all metastatic causes of solitary pulmonary nodules. You have benign infectious granulomas that can cause a pulmonary nodule, and those would be like TB, histoplasmosis, atypical mycobacteria, coccidiomycosis, cryptococcus, and blastomycosis. Benign neoplasms would be like lipomas, hamartomas, and fibromas, and vascular causes would be like AV malformations that can cause a pulmonary nodule. So lung cancer is basically divided into adenocarcinoma, squamous cell carcinoma, small cell carcinoma, and large cell. So in adenocarcinoma, that's the most common. That's an incidence of 40 to 50%. The location is it's peripherally located, and it's associated with clubbing. And another word for clubbing is hypertrophic osteoarthropathy. Squamous cell carcinoma, its incidence is less, 20 to 25%, and these occur centrally located in the lung, and they're also associated with necrosis and cavitation, as well as hypercalcemia due to parathyroid hormone-related peptide, the PTHrP. Small cell carcinoma of the lung, its incidence is less, 10 to 15% of the time. It's centrally located and clinically associated with Cushing's syndrome, SIADH, Lambert-Eaton syndrome. And then finally, large cell carcinoma is the least common at 5 to 10% incidence. It's located peripherally, and it's associated with gynecomastia and galactorrhea. One cool little thing here is that the tumors that are located centrally are the ones that start with the letter S. So squamous cell and small cell are centrally. It's also due to smoking, which starts with the letter S. Adenocarcinoma is going to be the most common type in non-smokers, and the stage at the diagnosis is going to be the most important prognostic factor, with the survival determined by its ability to be resected. Okay, lung cancer screenings. The recommended test is a low-dose chest CT. That's how you test it. Test lung cancer is with a chest CT. You want to do recommended intervals that are yearly, so yearly CT scans for cancer screening. The age for screening is between 55 to 80 years of age. The ability for screening based on smoking history means that the patient should have been smoking more than 30 packs per year, and the patient is actually a current smoker or quit smoking within the last 15 years. So if they said, I stopped smoking 10 years ago, obviously you congratulate them, but they're still at risk here. So because it's within 15 years. So that's another screening recommendation. And then the termination of screening is when they're older than 80 years of age, or if the patient has successfully quit smoking for more than 15 years, or if the patient has other medical problems that significantly limit their life expectancy, or their ability and willingness to undergo lung cancer surgery. Paraneoplastic syndromes is the next topic. So common paraneoplastic syndromes are associated with lung cancer, like endocrine, hematological causes, neurological causes, musculoskeletal causes as well. So an endocrine causes would be SIADH, hypercalcemia due to an increase in parathyroid hormone-related proteins, and Cushing's syndrome due to ectopic adrenocorticotropic hormone production. And that's generally associated with small cell lung cancer. Hematological causes would be hypercoagulability states like Trisell syndrome and deep vein thrombosis. Neurological causes would be like Lambert-Eaton myasthenic syndrome, which is also associated with small cell, and ataxia, autonomic or sensory neuropathies. And then finally, musculoskeletal causes of paraneoplastic syndromes that are associated with lung cell would be the clubbing, the hypertrophic osteoarthropathies, and the dermatomyositis, polymyositis. Those are causes of lung cancer. SIADH is a small cell lung cancer, stroke, hemorrhage, pneumonia, or drugs. And that's all going to cause an increase in antidiuretic hormone. That increase in ADH is going to inappropriately increase the ADH, hence SIADH. And that's going to decrease the plasma osmolarity, causing a hyponatremia and an increase in urine osmolarity more than 100 milliosmoles in the urine sodium. So that urine sodium concentration, if left untreated, can cause significant hyponatremia, which then causes seizures and a coma. And the treatment for SIADH would be fluid restriction, which is the most important in those who can actually tolerate being fluid restricted. And if severe symptoms or non-responsive to the symptoms, you want to give hypertonic saline. Demeclocycline is going to be considered if fluid restriction and an increase in salt intake really don't resolve the condition. Demeclocycline can be nephrotoxic, however, because it works at the collecting tubule to inhibit the action of ADH. And there's no role of thiazide diuretics to help SIADH, but loop diuretics and salt tablets can be given. Now, digital clubbing, we said that was osteoarthropathy, hypertrophic osteoarthropathy. The conditions that are commonly associated with digital clubbing would be intrathoracic neoplasms, such as bronchogenic carcinoma, metastatic cancers, malignant mesothelioma, and lymphoma. You have intrathoracic supportive diseases like lung abscesses, empyemas, bronchiectasis, cystic fibrosis, and chronic cavitary infections like fungal infections and mycobacterial infections. And then lung diseases like idiopathic pulmonary fibrosis, asbestosis, pulmonary arteriovenous malformations can give you the digital clubbing. And then cardiovascular diseases like cyanotic congenital heart diseases can also give you clubbing. Digital clubbing is a bulbous enlargement and broadening of the fingertips due to a CT proliferation at the nail bed, and the distal phalanx. So the diagnosis here is when the angle between the nail fold and the nail plate is more than 180 degrees. That's called your Lovibond angle. So normally it's 160 degrees, but when you have clubbing, that goes up to 180 degrees. So it's kind of like it flattens out because the nail bed grows tall and it becomes flush with the distal phalangeal joint. And these can occur, it can occur by itself or in association with hypertrophic osteoarthropathies, which is like a painful joint enlargement, periostosis of the long bones, and synovial effusions. It could be hereditary, but it's most often due to pulmonary or cardiovascular diseases. And most common causes would be lung malignancies, cystic fibrosis, and right to left cardiac shunts. The pathogenesis is that there's a circulatory disruptions from tumors and chronic lung inflammation that leads to the megakaryocytes, and that skips the normal route of fragmentation by pulmonary circulation. So it's just an accumulation of megakaryocytes. Those megakaryocytes are going to enter the systemic circulation. It becomes entrapped in the distal fingertips, and that's due to the large size, and that secretes prostaglandin growth factor and vasoendothelial growth factor. Then you have capillary permeability and vascularities that causes the clubbing. COPD also causing hypoxemia alone in the absence of a malignancy does not cause clubbing. COPD plus clubbing is basically an occult malignancy. So COPD by itself with no malignancy shouldn't cause clubbing. But if COPD is associated with a malignant state, that should cause clubbing. Hypertrophic osteoarthropathy is basically the digital clubbing plus a sudden onset of arthropathy, and that's commonly affecting the wrists and the hand joints. So hypertrophic pulmonary osteoarthropathy is a subset of hypertrophic osteoarthropathy, and that's due to the underlying lung disease. It's usually due to an adenocarcinoma. Chest x-rays are going to be appropriate as the initial study for the underlying disease or the underlying cause. Mediastinal germ cell tumors, these are primary mediastinal germ cell tumors, are common in young male patients. Locally, they're invasive, and beta HCG is going to be elevated in both seminomas and non-seminomas. So what are some of the non-seminomas germ cell tumors? These are large mediastinal masses that have increased amounts of alpha-fetoprotein, unlike the seminomas, which have and then they also have beta HCG like seminomas. So seminomas have increase in beta HCGs, but they don't have alpha-fetoproteins. Virtually are diagnostic. So clinical features of non-seminomas are cough, chest discomfort, dyspnea on exertion. It's confirmatory with a biopsy, and you want to perform a testicular ultrasound to rule out primary tumors, as managements and prognoses are going to differ in both cases. Almost all germ cell tumors are in the mediastinum are primary rather than metastatic. Okay, seminomas germ cell tumors have a mediastinal mass with an increase in beta HCG. So seminomas, high beta HCG, non-seminomas are increase in alpha-fetoprotein. So the seminomas are benign teratomas from 3 germ layers, and those can also present as a mediastinal mass, but it doesn't produce tumor markers. All right. Next one is Pancoast tumors and superior pulmonary sulcus tumors. Now, the clinical presentation of a Pancoast tumor is that there's shoulder pain. That's the most common. Horner syndrome as well, with ipsilateral ptosis, meiosis, and ophthalmos and anhidrosis from involvement of the paravertebral sympathetic chain and the inferior cervical ganglion. It's C8 to T2 neurological involvement. There's weakness or atrophy of the intrinsic hand muscles, as well as pain and paresthesias of the 4th and 5th digits, the medial arm and the forearm. Then there could be enlargement of the supraclavicular lymph node, and weight loss is also associated with Pancoast tumors. The patient can also develop an increase in the sympathetic activity, causing flushing and sweating on the contralateral side of the face during exercise. That's called your Harlequin sign. And most Pancoast tumors are non-small cell lung cancers. The initial evaluation for a Pancoast tumor would be to do a chest x-ray, followed by a CT or MRI. The CT and MRI of the brain is also part of the later evaluation, and that consists of an increased risk of brain metastasis. Aspergillosis is our next topic. Pulmonary aspergillosis risk factors would be immunocompromised patients, patients who have asthma or COPD, cavitary lung diseases like TB and sarcoidosis, as well as other malignancies can cause causes of pulmonary aspergillosis. Clinically, they present with pleuritic chest pain, dyspnea, cough, hemoptysis, and on lab imaging, there's a positive Aspergillus IgG plus radiographic evidence of a single multiple nodules, as well as cavities like with or without the fungus ball. There's consolidation, and there's peribronchial infiltrates. And the treatment for a pulmonary aspergillosis is to surgically resect it. If it's invasive aspergillus, then you want to give voriconazole or caspofungin. Itraconazole or bronchial artery embolization can also be used. But remember, you also want to rule out TB, and it can also occur with bronchogenic cysts and bullae. Next up, we have ankylosing spondylitis. So ankylosing spondylitis signs and symptoms would be low back pain. It occurs in patients less than 40 years of age, and the onset is insidious. It improves with exercise, but not with rest, and they have pain at night. So that's a good question. A young person that has back pain, hip pain, and buttock pain. There's limitation to chest expansion and spinal mobility because of the pain and because of the curvature of the spine. Enthesitis, which is inflammation at the site of the insertion of a tendon to the bone. There can be systemic symptoms like fevers, chills, fatigue, and weight loss. And acute anterior uveitis, which is unilateral pain, photophobia, and blurry vision. It can also be associated with irritable bowel disease and cardiac involvement with aortic regurgitation. The PFTs can give you a restrictive pattern. So there's a decrease in vital capacity, there's a decrease in total lung capacity, but there's a normal FEV1 FVC. And then there's also a normal FRC and residual volume. And that's due to the fixation of the rib cage in an inspiratory position. Ankylosing spondylitis can also cause pulmonary fibrosis as a restrictive pattern. So again, obstructive versus restrictive lung diseases. Obstructive lung diseases, the FEV1 is going to be low, less than 80%, because it's obstructive. You can't expire, right? The FEV1 FVC ratio is also low, less than 70%, but the FVC, forced vital capacity, is normal, but it could be decreased as well, but it's normal or decreased. In a restrictive lung disease, FEV1 is also decreased, less than 80%, but the FEV1 FVC ratio is greater than 70%, and the FVC, forced vital capacity, is less than 80%. And finally, we have hypothermia. Clinical features of hypothermia, the classifications is mild, moderate, and severe. Mild hypothermia means that their body temperature is between 32 to 35 degrees Celsius, which is 90 to 95 Fahrenheit. They have tachycardia and tachypnea. There can be ataxia and dysarthria with increased shivering. That's mild hypothermia. Moderate hypothermia is when the body temperature goes down even more at 28 to 32 Celsius, which is about 82 degrees to 90 degrees Fahrenheit. And those patients will have more severe features like bradycardia, lethargy, hypoventilation, and their shivering response is decreased, as well as atrial arrhythmias. The shivering is autonomic response. The muscles are just there fluttering to increase temperature. So in moderate hypothermia, it's decreased shivering. And in severe hypothermia, the body temperature is less than 28 degrees Celsius, which is around 82 degrees Fahrenheit. They can be in a coma state, cardiovascular collapse, and ventricular arrhythmias. Treatment, general treatment is you want to warm them up to about 105 degrees Fahrenheit with crystalloids for hypotension, as well as endotracheal intubation if they're comatose. And there's different types of rewarming techniques, and it's obviously for different types of hypothermias, mild, moderate, or severe. So for mild hypothermia, you want to rewarm them by passively external warming techniques, like remove the wet clothing, cover them up with blankets. If there's moderate hypothermia, you want to actively rewarm them externally with warm blankets, with heating pads, and with warm baths. But if they have a severe hypothermia, then active internal room warming is required, and this is warmed pleural or peritoneal irrigation, as well as warmed humidified oxygen. Tachycardia in mild hypothermia is due to peripheral vasoconstriction. Bradycardia and hypotension in moderate hypothermia is due to a decreased reactivity of pacemaker cells. That's why they're unresponsive to atropine and cardiac pacing. And then salt water losses from the cold-induced diuresis. So finally, what are some of the pointers for respiratory? Is that incentive spirometry should be given to prevent atelectasis in bed-bound patients, particularly following a surgical procedure. So that's always the go-to is to do a spirometry after any kind of surgical procedure to prevent atelectasis. Chest physiotherapy is used in patients with pneumonia or atelectasis, and that's done to loosen and promote expectoration of the secretions, and patients with bronchiectasis are going to need physiotherapy for a very long time. Alpha-2 adrenergic agonists like dexmedetomidine, that's used for the sedation in ICU patients. And then Candida is an extremely rare cause of pneumonia in any patient with colonizing bronchial epitheliums and contaminates of sputum culture. So you always want to look for something else. Think Candida if the question is going to say esophagitis or endophthalmitis, endocarditis, hepatosplenic diseases, or meningitis. So if you see any of those in the question, then that's the only time where you should be thinking that Candida is a cause of a pneumonia. And that's the end of respiratory. So since we finished internal medicine of pulmonary, now we're going to do pediatrics pulmonary. So we're going to delve into foreign body aspiration. So clinical manifestations of foreign body aspirations are a history of choking, 80 to 90% of cases, coughing, sudden onset of respiratory distress, cyanosis, as well as altered mental status. On physical exam, there's focal monophonic wheezing on the affected side with a diminished aeration on that affected side. So there's generalized wheezing, inspiratory stridor, hoarseness, and respiratory distress. And on radiographic imaging findings, there could be hyperinflation or atelectasis of the affected side with visualization of a foreign body. Now that foreign body is going to cause a partial obstruction, and that partial obstruction is going to cause air trapping in expiration, and that's going to cause a hyperinflation. Complete obstruction by a foreign body, that can lead to atelectasis, a post-obstructive pneumonia, and localized bronchiectasis. Foreign body aspiration is very common within 1 to 3 year olds. Peanuts and popcorns and pieces of toys is the most common cause. More than half end up in the right main bronchus, and for both diagnostic and treatment, you want to do an immediate rigid bronchoscopy. Next up is epiglottitis. On microbiology, this is due to H. influenza type B, or it could be due to non-typable H. influenza or strep or staph. Clinical features would be distress, like they're in a tripod position and with inspiratory stridor. They can have dysphasias and drooling. That's epiglottitis. X-ray findings is your thumbprint sign, and that's your enlarged epiglottitis on X-ray, and loss of the vesicular space. Management is to keep the child calm and comfortable, and then you want to do an endotracheal intubation in the OR. There's a high-grade fever also present. Management should not be delayed for diagnostic studies. If diagnosis is unclear, you want to perform a chest X-ray. If the endotracheal intubation is unsuccessful because there's too much inflammation, then you want to perform an emergency tracheotomy. A cricothyroidotomy should not be done in prepubescent patients because the upper portion of the trachea is underdeveloped in children less than 12. And then it can have an increased risk of subglottic stenosis. For viral laryngotracheal bronchitis or croup, these patients have that steeple sign on X-rays with the barking cough and inspiratory stridors that require nebulized racemic epinephrine. So bronchiolitis, this is found in patients less than 2 years of age. The most common cause is RSV, respiratory syncytial virus. And in patients that are older than 2 years of age, that's usually self-limited. They get mild upper respiratory infections like nasal congestions and rhinorrhea. So less than 2 years of age, that causes lower respiratory infections, and that's more severe. So bronchiolitis is more severe in less than 2 years of age. Clinically, they present with an antecedent of nasal congestion and discharge and cough. wheezing and crackles with respiratory distress like tachypnea and retractions and nasal flaring. Treatment is supportive, so you want to give them hydration, saline nasal drops, and nasal bulb suctions. You want to prevent with palivizumab for infants with the following conditions. So if they have a preterm birth that's less than 29 weeks gestation, or chronic lung disease of prematurity, or if they're hemodynamically have a significant congenital heart disease, that's how you prevent it with palivizumab. Complications with bronchiolitis is apnea, especially if the infant is less than 2 months. In addition, they tend to develop recurrent wheezing throughout childhood, as well as respiratory failure. Bronchiolitis is also associated with an increased risk of acute otitis media in up to 10% of the causes. Moving on, we have laryngomalacia. In laryngomalacia, the pathophysiology is an increased laxity of the supraglottic structures. Clinically, they have inspiratory stridor that worsens when they're supine, when they're crying, or when they're feeding, and then it improves when they're in the prone position. Laryngomalacia begins in the neonatal period and peaks at 4 to 8 months of age, and it resolves between 12 to 18 months old. The diagnosis of laryngomalacia is with a flexible laryngoscopy that shows collapsing of the supraglottic structures with inspiration and that omega-shaped epiglottitis. And that's usually clinical to confirm with a flexible fiber optic tube so that you can do diagnose laryngomalacia. So that's a laryngoscopy with a flexible fiber optic tube. That's how you usually confirm it, but it's mainly clinical. Management is reassurance for most cases, supraglottoplasty for severe symptoms like poor weight gain, apnea, and cyanosis, or rapidly worsening stridor. Most patients have symptomatic or GERD reflux like vomiting, arching of the back with feeding, poor weight gain, and that's treated accordingly, like an upright positioning after feeds and acid reducers. Anaphylaxis, a severe allergic reaction, sudden in onset and affects more than one organ, like the oropharynx, the lungs, the GI, the cardiovascular system, or the patient collapses after exposure and it can be fatal. That's all signs of anaphylaxis. It's common in patients with first-degree relatives with allergic diseases, and the treatment would be intramuscular epinephrine, proven to prevent and reverse the progression of anaphylactic shock and death. Beta-2 effects causes the bronchodilation, and it inhibits the release of the systemic inflammatory mediators and alpha-1 agonists that cause vasoconstrictions, and it also raises the BP and decreases the upper airway edema. Next up is cystic fibrosis. The clinical features of cystic fibrosis are divided into respiratory features, GI features, reproductive features, and musculoskeletal features. So the respiratory features of cystic fibrosis are obstructive lung diseases like bronchiectasis, recurrent pneumonias, and chronic rhinosinusitis. GI causes of cystic fibrosis would be, or not causes, but signs would be obstruction 10 to 20% of the time, or a 10 to 20% obstruction, meconium ileus, distal intestinal obstruction syndrome. For pancreatic diseases like exocrine pancreatic insufficiency, there's also cystic fibrosis related diabetes, and then biliary cirrhosis. Reproductive causes like infertility that can be caused by cystic fibrosis, more than 95% in men and around 20% in women. So remember, cystic fibrosis makes the mucus and the secretions very viscous, so sperm will have hypomobility, and that's why they're more common to have infertility in men with cystic fibrosis than in women. Musculoskeletal effects would be osteopenia leading to fractures, kyphoscoliosis, and digital clubbing. So for cystic fibrosis, they get chronic sinopulmonary diseases like bronchiectasis, like we said, GI and nutritional abnormalities, pancreatic insufficiency, meconium ileus, and failure to thrive. There's a salt loss syndrome, like an acute salt depletion, and chronic metabolic alkalosis. Male urogenital abnormalities like obstructive azoospermia, and the diagnosis is one or more clinical features or history of cystic fibrosis in a sibling, or it could be made on a positive newborn screening test with an increased sweat chloride concentration that's greater than 60 on 2 or more occasions, identification of either two cystic fibrosis mutations, or an abnormal nasal epithelial ion transport, and that's a potential difference. Inspissated mucus in developing fetal genital tracts causes obstruction that develops the vas deferens, causing a congenital bilateral absence of the vas deferens, and that causes a transparent or no semen production, causing an obstructive azoospermia. In contrast, congenital aplasia of the uterus and the vagina, which is also called Mayer-Rokitansky-Kuster-Hauser syndrome, that's rare. Females with cystic fibrosis are going to be malnourished with amenorrhea and puberty delay, and that will then cause subfertility. So that's why you see it less commonly in females than in males. Viscous cervical mucus as well inhibits the sperm entry. The gold standard test is to do a quantitative pilocarpine ionotrophoresis. That's the gold standard test. Pilocarpine is applied to the patient's extremities, and then chloride levels are checked on 2 occasions. If it's abnormal or intermediate, then you want to do a DNA analysis. If that's equivocal, then you want to check the potential differences. Pancreatic insufficiency can appear in infancy. 10% of patients without pancreatic insufficiency in infancy and childhood are going to develop recurrent pancreatitis in their teens and in their 20s. And those with pancreatic insufficiency rarely develop pancreatitis. Obviously, right? They already have the pancreatic insufficiency. Why would they get pancreatitis? High energy expenditure because of dyspnea and coughing, that leads to malnutrition and an increased risk of infections and respiratory failure. The treatment here would be a high caloric diet, also pancreatic enzyme replacement, as well as fat soluble vitamin replacements. Neonatal respiratory distress syndrome is the next topic. Common causes of neonatal respiratory distress would be transient tachypnea of the newborn. There's respiratory distress syndromes and persistent pulmonary hypertension. So the pathophysiology of transient tachypnea of the newborn is inadequate alveolar fluid clearance at birth, and that's going to result in a mild pulmonary edema. Clinical features would be tachypnea that begins shortly after birth and then resolves by the 2nd day of life. And on chest x-ray, in transient tachypnea of the newborn, it's a bilateral perihilar linear streaking. Next one would be respiratory distress syndrome. This is the easiest one. This is the surfactant deficiency, and that's going to result in the collapsing of the alveolus and diffuse atelectasis. With severe respiratory distress and cyanosis after premature birth, because they didn't have enough surfactant, which is seen in prematurity. On chest x-ray, they can have a diffuse reticulonodular ground glass appearance, air bronchograms, and low lung volumes. And then finally, persistent pulmonary hypertension that should be suspected in all term and post-term infants. This is due to high pulmonary vascular resistance that's going to result in a right to left shunt and a hypoxemia or hypoxia. Clinical features is they have tachypnea and severe cyanosis, and on chest x-ray their lungs are clear but their vascularity is decreased. Pulmonary vascularity is decreased. Respiratory distress syndrome affects infants that develop the following features within minutes to hours. So within minutes they get tachypnea, respiratory rates more than 60, grunting, which is due to increased end expiratory pressures, nasal flaring, which shows a decrease in nasal airway resistance, and retractions due to intercostal muscle retractions that contract and pull in the compliant chest wall, as well as hypoxia and cyanosis that reflects the significant atelectasis in RDS. And this happens minutes to hours. The treatment would be continuous positive airway pressure ventilation, and that's the treatment of choice. Also, intubation, mechanical ventilation, and exogenous surfactants are reserved for severe cases. Meconium aspiration syndrome is a term and post-term infant born through meconium-stained fluid. The meconium is going to obstruct the airway and cause respiratory distress. And on chest x-ray, there's going to be patchy infiltrates. There's going to be coarse streaking of both lung fields and flattening of the diaphragm because of it. Next one would be congenital diaphragmatic hernias. And these are more common on the left than on the right. Left-sided hernias of the abdomen, so abdominal content, are going to herniate, causing an abnormal left-sided lung development. This is going to lead to a decrease in left-sided breath sounds with the heart shifting to the right. Because of that, there's abnormal right-sided lung development and there's a decreased right-sided breath sound. Hence, that's why they have pulmonary hypoplasia and pulmonary hypertension. That is then going to cause a concave abdomen and a barrel-shaped chest, leading to respiratory distress. Sometimes the diagnosis is done intranatally by ultrasound, and this can cause an esophageal compression as well as polyhydramnios. The management is to secure the airway, to secure breathing and circulation before doing any type of diagnostic studies. Remember, airway, breathing, and circulation, ABCs. Then following that, you want to do emergency intubation and cautious ventilation. So blow by oxygen and bag and mask ventilation are contraindicated because they can introduce air into the GI tract that exacerbates the condition. The airway is secured and the orogastric or nasal tubes are placed in connection with continuous suction to prevent bowel distension against the lungs. Then place the umbilical artery line for a continuous ABG and blood pressure monitoring, and then place the umbilical venous catheter for administrations of fluids and medications. So there's a lot of management there, but it's pretty self-explanatory. After the patient's stabilized, you want to perform imaging to check the correct placement of the tubes and then to confirm the diagnosis. Next up is APGAR scores. So APGAR scores APGAR stands for appearance, pulse, grimace, activity, and respiratory effort. So the appearance and color, so all these signs are going to be either 0 points, 1 point, or 2 points. So 2 points for appearance and color, that means that they're completely pink, their pulse is more than 100, they have cough or sneezing or crying initially, that's grimace. Activity and muscle tone means that they're active and spontaneously active and they're crying. And respiratory effort is that they have a good cry and it's regular respiratory effort. So all those are 2 points, and that's 2, 4, 6, 8, 10. There you go. But a score of 10 is very rare. 1 point is given if the body is pink, but the extremities are blue. The pulse is less than 100. If they grimace or whimper, if they have some kind of flexion on activity and muscle tone, or if their respiratory effort is slow or they have a weak cry. And no points are given if they're completely blue, if pulses are absent, if grimace to reaction is absent, if they're limp, or they have no respiratory efforts. So a score of 10 is very rare. A score of 7 to 9, that's mostly going to require no further intervention because that's mostly the what's the most common. A score of less than 7 is going to require further evaluation and resuscitation with a pulse oximetry monitoring and positive pressure ventilation. And if the heart rate's less than 60, you want to do chest compressions can be given. An APGAR score of 5 or I'm sorry, an APGAR score at 5 minutes is useful in assessing the response to the preliminary intervention. So APGAR doesn't tell you how the baby was born, or it doesn't tell you. All it tells you is how the baby is responding. So how it was born and how it's responded. That's it. So at 5 minutes, you do it again, and that's going to basically assess the response to a preliminary intervention. So most concerning factors are going to be heart rate and respiration. Extremity cyanosis is very common and may resolve in about 1 to 2 days. Central body cyanosis is going to raise a concern for respiratory or cardiac problems. And maternal factors that increase the risk for resuscitation is a very young maternal age, a history of diabetes or hypertension, or a history of substance abuse. And that's the end of pulmonary pediatrics. Moving along, we have pulmonary for surgery. So flail chest is a condition that occurs when there's more than 3 adjacent ribs that are fractured in more than 2 locations, and that's going to cause a segment of the ribs to close and its continuity with the remainder of thoracic wall, causing pain and shallow breaths and hyperventilation to compensate for the hypoxemia. That's your flail chest. However, the muscle splinting with recruitment of chest wall muscles can mask the motion of the involved ribs and make it clinically difficult to diagnose early flail chest. Flail chest can lead to pulmonary contusion, irregular non-lobar areas of opacification, and that can lead to a pneumonia and ARDS. On examination, flail chest is an isolated thoracic wall segment that exhibits paradoxical inward motion on inspiration and outward movement on expiration. Normally, when you take a breath in, your chest wall should move outward, right? You take a breath in and your chest should expand. But in this case, it's paradoxical. You take a breath in and the chest actually collapses. And when you take a breath out on expiration, that's when your chest wall expands. Kind of weird, but that's flail chest. The treatment here is pain control and supplemental oxygen. That's most important. Early steps leading to intubation with mechanical positive pressure ventilation required in many patients. A positive pressure mechanical ventilation is going to replace the normal negative intrapleural pressure during a spontaneous ventilation with positive intrapleural pressure, and that leads to a previously flail segment that moves out normal with the rest of the rib cage during inspiration. Pulmonary contusion is common after a blunt chest trauma. You get hit with a baseball bat in the chest. That's pulmonary contusion, or handlebars or something on a bicycle. Lung parenchymal bruising, and it develops within a day, usually a few minutes or hours. As the pulmonary edema sets in, a fluid challenge hastens and the symptoms appear. Clinical features would be tachypnea, tachycardia, a continued chest pain and dyspnea hours after a motor vehicle accident, hypoxia and hyperventilation, as well as hypocarbia and respiratory alkalosis. On physical exam, there's bruising of the chest wall with decrease in breath sounds on the side of the contusion. On chest x-ray, you'll see a patchy irregular alveolar infiltrates or alveolar opacities of the right and left lower lobes. The CT is done to make an early diagnosis, and the differential diagnosis for pulmonary contusion would be like acute respiratory distress syndrome, ARDS, that develops 24 hours to 48 hours after the trauma. It's usually bilateral though, in the lung involvement is bilateral, and the treatment for pulmonary contusion is closely monitoring. Intubation and mechanical ventilation might be needed if the case is severe. Moving on, we have a pneumothorax. So clinical features of pneumothoraxes is that it could be either primary spontaneous pneumothoraxes, it could be secondary spontaneous pneumothoraxes, or it could be a tension pneumothorax. So a primary spontaneous pneumothorax is that there's no preceding event that caused it or a history of lung disease. It just spontaneously happened. A secondary spontaneous pneumothorax is
that it happened because of a complication or an underlying lung disease, secondary to something, right? If there's a tension pneumothorax, that's life-threatening because there's trapping of air within with a mediastinal shift, and that shift is going to compromise cardiopulmonary function. Signs and symptoms of a pneumothorax is chest pain or dyspnea. There's decrease in breath sounds. There's a decrease in tactile fremitus, and there's a decrease in chest movement. Also, there's hyperresonance to percussion on the affected side because it's now, a hollow area, like a drum, so it's hyperresonant. Tachycardia, hypotension, and or tracheal deviation away from the affected side. It's seen in tension pneumothorax. On imaging, there's noticeable visceral pleural line, an air in the hemothorax with contralateral mediastinal shifts and radiolucent costophrenic sulcus. So that's your deep sulcus sign. So the treatment here, if it's small, less than 2 centimeters between the lung and the chest wall and chest x-ray, you don't have to do much other than observe them and give them oxygen. However, if it's large, then you want to know if they're stable or not. If it's large and stable, then you can just do a needle aspiration or a chest tube. But if it's large and clinically unstable, or if they have a tension pneumothorax, then you need an urgent needle decompression, then a chest tube placement like a tube thoracostomy to maintain that pressure. Tracheal deviation is going to be to the right. That can be due to a pneumothorax, a hemothorax, or right-sided lung collapse. Also, distended neck veins can also be due to a pneumothorax and cardiac tamponade. An untreated tension pneumothorax is going to lead to a pulseless electrical activity or asystole. Although the first step is usually to intubate the patient when they have respiratory distress, but in patients with suspected tension pneumothorax, endotracheal intubation followed by positive pressure ventilation is done before needle. If that's done before needle thoracotomy, that can worsen the symptoms. So first you want to actually insert the needle to let that air out. Then you can intubate if needed. The needle thoracotomy can be done in second or third intercostal space in the mid-clavicular line, or the fifth intercostal space mid-axillary line. The chest tube is placed at the fifth intercostal space mid-axillary line. Patients with continued hemodynamic instability after a needle decompression should get a FAST done. A FAST stands for focused assessment with sonography for trauma. Examination to look for pericardial tamponade and the hemothorax for neck vein collapsing. That also requires a chest tube. Post-op pulmonary complications would be atelectasis or infections like a pneumonia. That's a post-op pulmonary complication. Bronchospasms, exacerbations of chronic lung disease, and prolonged mechanical ventilation. Risk factors for post-operative pulmonary complications would be if the patient's older than 50 years of age, emergency surgery or surgery duration that's more than 3 hours, heart failure or COPD, poor general health, and that's the American Society of Anesthesiologists class more than 2, a smoking cessation that's at least 8 weeks prior to surgery, symptom control of chronic obstructive lung diseases like preoperative steroids if not well controlled, treatments of any respiratory infections prior to surgery, patient education for lung expansion maneuvers like chest physical therapy, coughing, deep breathing exercises, or incentive spirometry. All these are preoperative strategies to reduce the risk of a pulmonary complication, a post-operative pulmonary complication. Post-operative strategies would be like incentive spirometry, deep breathing exercises, epidural analgesia instead of a parenteral opioid, and continuous positive airway pressure. Intermittent positive airway pressure can also be used post-op. The best strategy is going to be incentive spirometry, and that's done to prevent a pneumonia, and that's first line. A CPAP is going to be used in those patients who develop pulmonary complications in spite of incentive spirometry, as it's more expensive and has more complications. Atelectasis is next. This is a lobar or segmental collapse causing a decrease in lung volume, and it's classified based on the pathophysiology of obstructive or non-obstructive lung diseases. It's also the location and the portion of the lung involved. So this can occur post-operatively, especially after abdominal or thoracoabdominal surgery. There's accumulation of pharyngeal secretions, there's tongue protruding posteriorly into the pharynx, as well as airway tissue edema or residual anesthetic effects. Post-op pain is going to interfere with coughing and spontaneous deep breathing, and because of that there's going to be a decrease in the FRC or functional residual capacity, and that's going to worsen the atelectasis. If it hurts to breathe, it hurts to breathe. They're not going to want to breathe. Small areas of atelectasis is asymptomatic, and large areas of atelectasis is significant ventilation perfusion mismatch that can lead to hypoxemia and an increased work of breathing. That will then cause a tachypnea and dyspnea, and that will then lead to a respiratory alkalosis and a decrease in the CO2. So those manifestations start typically after the patient has left the post-anesthetic care unit, anesthesia care unit, and it's worse after the second post-op night to the fifth post-op night. Pulmonary embolisms can also occur after surgery and present with similar symptoms. Hemoptysis is our next topic. So common causes of hemoptysis are due to, so let's classify it by organ system. So pulmonary causes like bronchitis, pulmonary embolisms, bronchiectasis is in lung cancer. These are common causes of hemoptysis. Cardiac causes would be like mitral stenosis that backs up into the lung, and acute pulmonary edema. Infectious causes like TB and lung abscesses can cause hemoptysis. Hematological causes like coagulopathies, vascular causes like AV malformations in the lung, and systemic diseases like Wegener's granulomatosis, Goodpasture syndrome, and lupus, as well as vasculitises. So let's say there's a history and physical is done to rule out other causes like oropharynx or gastrointestinal causes of hemoptysis. You want to see how is the hemoptysis. Is it mild or moderate, or is it massive? Massive meaning that it's more than 60 milliliters per 24 hours or 100 milliliters per hour. If that's the case, you want to secure the airway, check breathing and circulation. If the bleeding stops, then you want to do a chest x-ray with CBCs, coagulation studies, renal function studies, urine analysis, and a rheumatological workup if suspected. If the bleeding does continue, then you want to treat the cause. You want to treat the cause of the persistent bleeding, and you want to treat that via a bronchoscopic intervention, embolization, or a resection. If there's a history and physical that rules out other causes like oropharynx or GI causes of hemoptysis, then and if it's mild to moderate hemoptysis, you want to do the chest x-ray, CBC coagulation studies, you want to check renal function, urinalysis, and rheumatological workup if that's suspected. And then you want to do a CT scan with or without a bronchoscopy. And that depends on the imaging result. If intervention is needed, you want to treat the cause and of the persistent bleeding, then treat via a bronchoscopic intervention like embolization or resection. Massive hemoptysis is the greatest danger in massive hemoptysis. It's not exsanguination, so you can't. It's not that you can't die of it. It's just not the greatest danger. But asphyxiation of the hemoptysis, due to the accumulation of that blood in the airway, is the greatest danger. So the initial step is to secure the airway, secure breathing, and circulation, ABCs. The patient should be placed with the bleeding lung in the dependent position, the lateral position, to avoid blood collection in the airway of the opposite lung. Remember we said that earlier, that whenever you have a consolidation of a lung, you want to put the patient on the side of the consolidated lung because of gravity, airway. The airways are going to be more permeable, and diffusion is going to act more naturally due to gravity. Air goes up, so that's why the unaffected lung should be on the top. So you want to secure the airway, you want to do a bronchoscopy, and that's the initial procedure of choice in a massive hemoptysis that directly visualizes the bleeding site and provides a suctioning ability to improve visualization and provide other interventions like a balloon tamponade or electrocautery. Then, if the bleeding still doesn't stop, you want to perform a pulmonary arteriography, and that basically identifies the bleeding vessel, and once you identify it, you can do a therapeutic embolization to control the bleeding. And that's, if it's still not controlled after that, then you want to do an urgent thoracotomy and surgical intervention. Fresh frozen plasma is used for those with a known coagulopathy, like an INR of more than 1.5. And then brain injury, finally, that's the last topic for respiratory in surgery, is the initial management of brain injury is the same as all trauma patients. You want to secure the airway, do the breathing and circulation as well, so ABCs. Burn victims are at the highest risk of respiratory compromise because the supraglottic region rapidly exchanges heat with the inspired air, and that's very susceptible to direct thermal injury and acute obstruction by edema and blistering, unlike the subglottic region, which is actually protected by reflex closures of the vocal cords upon exposure to extremely hot air. So supraglottic is at more exposure than infraglottic. Indications of thermal and smoke inhalation injury would be burns on the face, singeing of the eyebrows, or oropharyngeal inflammations. There's also blistering or carbon deposits in the mouth. There's carbon sediments in the sputum, stridor, carboxyhemoglobins of more than 10%, and a history of a confinement in a burning building. So the management of all burn patients is to be treated with high flow oxygen via a non-rebreather mask. You want to maintain a low threshold for intubation with physical evidence of thermal damage to the upper airway, and that's the key reason for early intubation would be progression of airway edema that can preclude intubation later on in the course that requires emergency surgical airway. Fluid replacement is also needed for fluid loss through wounds and injury-related systemic inflammatory responses like shock. And that's the end of pulmonary for surgery. And finally, pulmonary for OB-GYN. I promise this is the last one. Pulmonary for OB-GYN is amniotic fluid embolisms. So risk factors here are advanced maternal age, more than 5 live births or stillbirths, cesarean deliveries or instrumental deliveries, placenta previas or abruptions, and preeclampsias. Those are all risk factors for amniotic fluid embolisms. Clinically, they present with cardiogenic shock, hypoxemia or respiratory failure, as well as DIC, coma, and seizures. The treatment for amniotic fluid embolisms would be respiratory and hemodynamic support with or without transfusion. It can occur during pregnancy or shortly after a delivery. Amniotic fluid can enter the circulation via the endocervical veins, the placental insertion site, and the area of uterine trauma, which can cause an inflammatory response and then a vasospasm. So pulmonary or amniotic fluid embolism is diagnosed clinically after excluding other causes of cardiorespiratory failure like pulmonary embolism, pericardium cardiomyopathy, or eclampsia, and an oxygen mask, intubation, or mechanical ventilation can be used for hypoxemia, as well as vasopressors if there's hemodynamic instability. And that's the end of OB-GYN respiratory and the